All right, as the time progresses, more interesting things will come. The slide is quite a animated one. Um, you'll find it a bit different compared to a lot of past slides, actually. All right, so before we start, we have 1 minute. So just take 1 minute asking the candidates and the things. Um, So Dr. Kaihan, Dr. Faiza, how things are going? I mean, studies and the things, you can be online. We have 30 seconds to share how you are planning actually for with your preparation and the things. Dr. Kaihan,
Yes,
you are
sir.
there? Yes, how are you
Yes.
doing, Doctor? Preparation
Yes,
apart
sir.
from your duty, how many hours you are managing?
4 to 5 hours daily now.
All
I'm
right,
trying to
that's fine.
improve it. Yes.
Suddenly, if I ask that, that will look like a STD history lab. Anyways, I mean, do you have a stable study partner?
Yes, yes. Yes. They are
Suddenly,
pretty much
it seems
stable from
no,
AMC.
no, that's the question nowadays, right? Because many complaint came, doctor,
Yes.
I'm trying, my study partner ditched me, So I felt it somewhere like a STD history, like so. Do you have a stable? So that's a character, the stable partner. It will look really offensive. So stable study partner, it is important actually. That's also history thing in AMC. A lot of plus point, minus point for AMC, but stable study partner or partners. So here partners are useful. In real life, if you have a multiple, it's not good idea, of course. But uh, here in AMC, if you have more partners, it's always very useful. Actually, you all need to understand that. I mean, it's very useful if you have one partner. You can also target some of the junior, like now see, doctor, those of the doctors are studying with us. You guys are a bit confident now, actually. So some juniors, you might also find they're planning for MC clinical. So don't hesitate them. It just sometimes just bring, okay, I will present a case to you because they just want to hear in the beginning. So don't hesitate to target them as well, actually. So whoever you find, make them a role player and keep practicing. Whenever you will do it something, you will get more confidence. All right. So that's one of the point. Um, yeah, and I will invite Dr. Faiza after a while. Initially, I'll talk about a bit in the cardiology. A few of the classes are coming. This Saturday is a class, Cardiology 1, then Tuesday will be Cardiology Class 2, and next Saturday will be Cardiology Class 3. So I've divided into 3 parts just to make it more easier for you. Try to involve as much as new cases also possible. So in the last class, we'll try to also discuss some more new recalls. I mean, recalls will be there throughout the all classes and the cases. First class, there will be a little theory thing will also come up, but we'll also promise to do a lot of role play actually, because role play is the ultimate thing. Some doctor asked me, doctor, what is the passing rate? Normally, passing rate we can say 15 to 20%, but if you see the May, it might not be that good. I mean, how we were expecting online. So something is not going right, probably. I mean, so you need to be more careful on that one. Time to time, we'll try to update you guys. I mean, what mistakes and the thing. A lot of doctors complain also about, you know, screen freezing, internet errors. They got puzzled because suddenly line is disconnected. So is there gonna be counted for that case actually? So a few of the informations we heard, which I will share throughout. So for that one, you have to attend the whole class. Time to time, I will share those stories and the things. So more doctors are going in the June, somewhere going. One two doctors in the July. There will be a few, 2 or 3 from my academics going. So we'll get more updates from them, and I will convey those updates to you guys with time to time. There's some feedbacks out there, but unless you talk to someone who appeared in the exam, that's more logical, right? With that note, we are today our classes on cardiology. I hope I can give you a nice um, session on the cardiology. It's a bit rainy day, as you can see here in my computer is showing. It's a bit rainy day, light rain here. Um, so before you start, please let me know from which country and city you are attending that class in our comment section. So at this time, so hi, hello everyone. This is your mentor, Dr. Shahriar. In my classes, I try to use the video conversation and the thing, and the whoever will do the role play, we'll also invite in the same way, because in the main classes, I mean main exam, if you go, especially the online base, it will be face to face. Even the main exam, if you go, it's also face to face. The person will be there, so your eye contact and also many of the things are counted. So please let us know in the comment section, like from which country and city you are attending the class right now. All right, so if I just check, it's just called involvement actually. So, all right, a lot of doctors from India, Nepal, Bangladesh, Australia, I'm sure. So thank you so much. I want everyone to participate. All right, never mind. Good to know. We can start, I guess. Yeah. So next coming up, the things. Okay. Now, do you know the top 5 sectors? I think you know. I'll just tell it in my way. That might be a little bit useful for some of you there. So let's go and explore the session. Yeah. So first of all, the top 5, the important thing, read your case very well. I repeat, read your case very well. You have seen, those of you who are doing role play with us, many times, if you guys remember, you were given 2 minutes, you read the case, you start doing role play with us, and then suddenly it happened that you are not supposed to take the history in that details, and but you were involved in asking lot of things, I mean regarding the history and the certain things in that case. Okay, so you have to be careful on that one. Read your case very well. Why? Because of your task. Last time, if you remember, in some of our early classes, there's like a 5 component also, like not key to success. I mean, if I count from the history, then physical examination or PEFE, then comes the investigation, then comes the diagnosis, DD, and the management. So there's a 5 component. You will not always be given the 5 component. Okay, what's new update? Is 5 components are given in the recent exams? Probably yes, the same thing, like around 2 cases you will find, 2 or 3 cases, all you have to cover. All right, so this is some of the information, but normally you are given 3 to 4, component to cover. I hope so you are getting me what I'm trying to say here. Like, you might not be given management. You might not be given the history some cases to take, because otherwise the case becomes too long actually. Sometimes they will be also testing your ability to speak faster, the patience, because if it's a longer case, you have to talk very fast and finish things in a smart way. So your presence of mind, they also like to see, and everything goes with the first one. Read your case very well. You have the time to think. One more information. In case of AMC, there's a one thing about writing. I'll clear that one today. I have talked to some of the candidates. I mean, writing few things. Maybe you have a A4 size paper or whatever thing like that. You have to do that security check. I mean, whatever you have in your desk, on the things on the other side of the room, this side, that side, no one can enter in your room, and it has to become quite good. Internet connection is very important. Large size monitor is very important. Do not use 13-inch laptop devices, because many of you have 13-inch laptop devices, because some of the thumbnail are very smaller. So then you just have to come like that all the time. You have pressure on your eyes. So if you have, I mean, say example, I have a 16-inch laptop which I'm taking class right now. It's quite easy to read, but many of the laptops, even MacBook and the things, the monitor is small. If you see me in the side, if I just give you a little demonstration, it's my side monitor. I have a side monitor, a big one, that's the 21-inch. So if you have some things like that, in that case, I'm sorry. So in that case, it would be more useful for you guys. Like if you can use a monitor like that. Right? So this is few of the quick tips. I mean, for the new Zoom-based exam, as I said, you have to take the whole class. Time to time, I'll tell more thing. Next important thing is your approach. Like when you enter in the room, I'm talking about in general. It can be in person. Many of you will get the exam in person. So actually, what happened when we enter? So there's some hooter or bell rang, and then that we open the door and we greet the examiner. So we enter with hello, dear examiner. This is my for example, this is my say ID, right? So it's kind of like that. Okay, so that's it. So that do you understand your case and this sort of things? Yes, I do. Okay, is your patient? Paula is waiting. Or says the patient is waiting. You can go and start. If it's a center-based exam, you definitely enter. You take the sanitizer to do the hand wash, right? And before you enter, it will be displayed to you, so you can just read that one. So it varies. So with exam to exam, you might be given some small note or check, like you can bring it to the exam hall. Actually, if it's a center-based, actually, like that same case, you might be given in hands actually. So that varies with some of the years actually. Sometimes it's given, sometimes not. All right. So, but online-based exam, if I tell you, doctor, is my case would be displayed in front of me throughout the time? Answer is a yes. It will be throughout displayed. Now, what's difference? The difference is physical examination. The typical one is gone. Though, so the physical examination is now, few of the cases are to the medical students. You have to explain it more nicely with some landmarks and the thing. Time to time, I'll update you on that one. So some of the surface landmarks, I mean, that's like a teacher, how a teacher is explaining to a med school students. I mean, your register is to teach you, right? Okay, see this, see that. So more specific and crunchy it has to be, right? So these are some of the points especially in the Zoom based exam. The real life exam, if you enter, so that either there would be physical examination by touching patient, either there would be physical examination finding to examiner actually. So you will get to know by reading your case. By the way, your instruction will be very clear in the main exam. Like whether you need to do physical examination or not, it will be very clear. In online-based exam, they have cleared it very beginning that no need for physical examination. Also, there is a new word they use, I think, that is prompting. All right. So at the 4 minute, they will prompt and they will tell you some more things, and so that few of the things will be there actually, like prompting. All right. Now, next few of the things. Okay, we have a question, I guess. Okay, so late, I mean, lately. Okay, so good to know from Spain. I hope so. Spain is open now, from by the way, for a lot of countries. Anyway, next is very important. There's a reason many doctor fail is a time management, as you can see. So lack of time management, many doctor fail. You have to finish it in 8 minutes here. Is no matter what it is, you have to finish it in 8 minutes. Some doctor take too much time in the history. They didn't get to manage the management part well. So it's easy everything, whatever that's written is very important. So read your case well, then comes to the approach. You enter showing ID. Even Zoom-based online exam, you have to show your ID. Important information. In Zoom-based exam, you will be emailed your some of the AMC document, which you have to take print out 24 hours before, and you have to show it to the during the exam, and along with your ID. So you have to show it actually in the exam day, okay, by a video. So this is how things would be, and you have to show it like that. So these are some of the points. So when you enter, say example, if there's a role player talking about the real life, so enter, introduce yourself. Hi, I'm Shahriar, one of the GP here today in this clinic. How may I help you? See, this is my first intro. Like, I'm a GP in this clinic. Another way it can be, hi, I'm Shahriar, one of the junior medical officer of this year of this hospital. So please clear the doubts, clear your position. No need to tell doctor 2 times. Say, hi, I'm Dr. Shahriar, one of the junior doctor. It looks weird. Hi, I'm Shahriar, one of the junior, and you can call me Shahriar. Right? So in those countries, people call by name, so it's very common. And then when you start, like they'll ask, from the note I can see your name is John, but how may I address you? Because you might want to, okay, well, call me John, that's fine. Right? So that's the initial approach. If the case demands, like, any pain and the things, I can see from the notes that, you were having pain. So can you, rate your pain in a scale like 9 to 10? And do you want me to give some kind of painkiller? They'll say, yeah, I'm having a lot of pain. So can you rate your pain, buddy? 1 being the lowest, 10 being the highest. So say, yeah, I think it's 9 by 10. So do you want me to give some painkiller? Yes. I'll take some more moment to turn back to my examiner. And so this is about the pain thing. There's another point about the vital assessment. So initially, we also assess the vital. If it's a case about chest pain, of course, your patient can be unstable. There can be cardiogenic shock and things like that. So you also tell the patient, John, I hope you don't mind. I will turn back to my examiner, and so he will give you permission, and then turn to the examiner. Dear examiner, can you tell me about the vital of John? I want to know starting blood pressure, pulse, temperature, respiratory. Okay, the things I'm saying, just tell in that way. I don't know about vital. So the examiner will also look at you like a vacant look. They're expecting that you will be telling the points. I mean, you actually wanted to know. So, dear examiner, can you tell me the vital of John, starting from like blood pressure, pulse, temperature, respiratory rate, and saturation? Sometimes there's a key question or secret question. So, is there anything I should know? No, you can go with that. Okay, because if there's additional information, additional thing like that, they will also give you. So that's sometimes a key thing in this case. So when you're approach, so these are the basic approach when you enter a clear country English, um, and your flow of talking. So all these things are very important. So after doing things, so okay, dear examiners, I'd like to get back to job. So you take the permission, just get back. Let's start the case actually. So this is your approach, initial approach, and throughout the approach, they will see if you're a good listener, they will also see that. Okay, there's some doctors because they're in too hurry, they don't allow the patient to talk much because we always need to start with an opening statement. So that also is under the approach. So hey John, can you tell me what brings you to this clinic? Don't worry, I know I'll be help you throughout. I'll be very gentle to you. Please tell your problem actually. Don't hesitate. All right. So he will tell about the problem. Sometime you can add some word like, is there anything I should know? Like, whenever the history is finishing, now that, the secret recipe thing you can bring, hey, John, is there anything else I should know? You say, no, that's all. You'll say, that's all. That means the station thing is done. Sometime examiner might tell you, if you go to the real life exam, examiner will tell you, stick to your task. That means you are going outside the task actually. Unnecessary things it might be asking. Okay. Now in the main exam, I mean in this Zoom-based exam, this option is not there. Examiner won't tell you these things. So they will be hidden somewhere in the screen. Only you'll get to see the role player actually. All right. So time to time, as I said, I will guide you guys more actually. All right. Definitely before your exam, try taking uh, more mock test so that you can practice really well actually. Right. So if you're going for real-time exam, I highly recommended you should take a real-time 60 nations. Some of the it's available in the Australia. I would recommend that one actually. That if your exam is center-based, you should take those center-based exams. Yeah. Because no matter how much flavor we give in the online, 16 is station-based. If your exam is Melbourne NTC-based, you should take one of them actually. Here's online based. We have full setup now available actually for same like the Zoom delivery system and the things. Also we have the buttons now. If you click, the physical examination will be popped up in the screen. So we have these things now. So those are going online based exam. Highly recommended. You should take at least one mock with us. We have very limited slot for that because those mock I conduct personally. All right, so I have very limited slots. I have to take classes, MCQ clinical, and also PLAB exams actually. So those slots every month I have only 4 slots. So only 4 people can take my mocking per month actually. All right. Now this is the thing. So read the case well. Approach time management. Time management. So 2 minutes to read the question, 8 minutes inside. Use it well. Do not spend all the time for the history. Keep the time for the differential diagnosis DD and the management. Next important thing is coming. How many DD I need to tell? There is 5 DDs. The basic structured, we say 4 to 5. Some people say, but let's say 5 on an average. Now they will also test you about your knowledge about your case. Actually, how smart you are. How nicely you're presenting. How much information you are providing to the case, and how the conversation goes on. Are you going in the right direction or not? These are the most important. So your knowledge about the case actually. And lastly, the strategy. If you divide the case in time, you cover up the main points. You cover up main points. For example, if it's in pediatrics we have done. If you do ask about the, if it's a ZERD case, and if you do ask about, is there any visible mass or any peristalsis. That means you try to know about pyloric stenosis, right? You are excluding the negative things. So that will give you additional points here actually. Okay, so that's called your strategy. That's called your strategy. Also, some of the strategy we ask about office test. We ask this smartly. Is there anything, any other test available for me? So here is the one part. Like, if you don't ask properly, they might not give you those information. Like they might have also radiology. They might also have ECG and those things. You have to ask, is there any supplied ECG available? Is there any radiology available for me? Is there this thing is available for me? Okay, so these important, things are very important. Another secret recipe I told at certain points, like at the history, I usually like to ask that one, is there any other information available for me? So no, it's fine, thank you. For the examiner, is there additional I think I should know? No, you can go forward. When you're finishing, you can also add that one. Is there anything additional I should know? All right, so this is some of the secret things, additionally you can do here. So that goes as history, strategy. I can tell a lot of things throughout, don't worry. So history will come one by one, don't worry on that one. The next thing is coming after that one. Okay, any question from this side? I want to hear from my dear doctors, like any question from your side, my dear doctors? All right, one doctor
Excuse me,
sent
doctor.
thing. Yes, doctor.
Yeah. When exactly does the 8 minutes start? As soon as you enter, or after the ID check? Is there a gap in between, or?
Uh, it's like a 2 minute that display.
Mm-hmm.
Once the display, time is over, the ID
Mm-hmm.
checking and those things are inside the 8 minute. Your
Okay.
timer will be on actually. They will not show you timer,
Okay.
obviously, but once the, there'll be bell ring, there'll be bell in the, or there will be a sound you will hear. Once that sound you will hear, that means your
Mm-hmm.
time has started. Then
So
this
in
ID
between,
checking, yeah, ID checking, then greeting and all this part is included in that 8 minute.
will we know like we have 4 minutes or 3 minutes left or something like that? Is there a bell
No,
for
no,
that?
no, no,
Okay.
it's not possible. Yeah.
Thank you.
So that's the drawback part. That's one of the drawback part actually. In main exam, if it's a Melbourne-based exam, you cannot take your watch with you. Neither they have anything displayed in the room so that you can see how much time. Neither in the main exam there is no display of the watch. Okay. I'm not sure some people secretly keep a watch near to the laptop or not, but if they find it out, it might be it's not allowed actually. But it's very easy to hide a watch actually, to be honest, in the Zoom-based exam. I could have I could have start that one with my laptop monitor actually somewhere
No,
because
but in Zoom, I think the time will be displayed on the screen, right? In the
no, no, no,
computer
no,
screen.
no, no,
No?
no, no,
No,
no,
I mean
no.
an art screen.
No, 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 not in. Oh, yeah. In the down bottom. Yeah. Yes. Yeah, yeah. The one you are watching now. Yeah. So that's one of the thing. Yeah. So that's. So now this is online based exam. So I believe this timing thing. You can, if you're smart, you can do like you can see that one in my screen as well, right? Yeah. So that's one of the part actually. Yes. Yeah. So
Thank you, doctor.
yes. Yeah, so let's keep it to ourselves, right? Let's let them, let not them, forward this information to them. Actually,
Sure,
yes.
sure.
All right, yeah. But end of the day, it's not the time thing; it's your strategy and all this thing that matters actually. But I wish we could know the time very well actually. So that's actually become easy, especially if we know okay we have less time. We increase our speed. Automatically, there is a adrenaline rush in that case. Okay. Okay, any more question, guys? Before we proceed, some could be new. So, I'll give more idea about the new Zoom-based exam very shortly. Anything about the main Melbourne NTC exam? Because we took the exam in the Melbourne NTC. Yeah. Okay, one doctor said, read the invigilator during the online exam would not be. No, no, no. They don't answer any question nowadays. That is true. If you go to online, if you go to the main exam, Melbourne NTC means the original exam. You can talk to them because they will be sitting right next to you. But in current one, they are hidden. They don't talk, and they're not going to answer anything. It's only you and the role player actually. Okay. Clear? Is this thing clear, everyone? the vigilator, whatever, the examiner. So they're not going to talk actually. So here you go, moving forward. If there is any question, do let me know actually. Now, some doctor actually, there's a lot of reason people fail actually. It's one of them, what thing, have you ever thought of that? What things are in the examiner's sheet? These are the things. So usually they look forward. So I want you to be very careful now. I'm especially the points I'm going to say. I mean, it's not about just you are very nice with the English, you are confident. It's not about that. There are some few points. If you touch them, they give you mark for that. Unnecessary information, they are not going to give you mark. Or too smartness is not always they're going to give you mark. Now, few things are here: patient counseling, education in nice, gentle way, history taking, physical examination choice. Like say there can be two examination. You choose one, the right one you are choosing, and your technique, of course. These are important. Physical examination accuracy. If it's the real time, of course, you have to be accurate. If it's the Zoom based, while talking to the med school student, you also have to be accurate, explaining the points. So it's moreover like a teacher is explaining to his student. So be the teacher for them actually. All right. So if anyone has history of teaching or tutoring, might be very easy these stations actually. All right, next will be choice of investigation. So some people uh, do not tell the necessary investigation, so they will want you to tell the necessary investigation. Do not miss the important one. Do not miss the important one. So these are the things. Secondly, diagnosis and the DD, 5DD, you have to be keep it in your mind. Initial plan, what you are managing, what management say. If it's a MI case, definitely, I mean, everyone, I mean, they will want you to give painkiller, monotherapy painkiller, and also followed by oxygen aspirin. So what is your initial management plan? But if you are keep thinking about that, okay, I'll give aspirin, but you forget about the pain. The patient is dying, I mean, because of pain. I mean, it's like an elephant is compressing chest and you don't give the painkiller. So that's not the always good idea. So your management plan, the initial plans are very important. Explanation of the clinical procedures, like that goes with the physical, medical student. You're explaining the clinical procedure. Even in the main exam, if there is a surgical procedure, you actually have to, like example, pyloromyotomy. Which case we have learned that one, guys? Let me recapitulate a little bit. Pyloromyotomy. If you remember, guys, some of you studied that one with me. I think I took that case.
Pyloric
Yes.
stenosis.
Yes, pyloric stenosis. So at certain point, this pyloric stenosis management will come, and there is a thing pyloric stenosis. You have to explain the procedure. We'll open up that domain, and these are the things. Usually, it's very safe, and then there will be patient's question you have to answer. Answering patient question also carries mark. That's very clearly evident. Like how you're going to answer those questions carries any straightforward marks on that one. Okay, so explanation of the clinical procedure, perform main clinical procedure correctly. That's important. Familiarity with test tube. Now, this is I like to clear to some of the dear doctors actually. Clinical equipment, it means like what? I mean, let me show you something. If you go to the main exam, I mean, those of you go to the Melbourne NTC, you'll have a table and things like that. And in that kind of table, there will be a lot of instruments available. And I think you remember last day class, I asked what are the instruments that can be available in the table. So, we recapitulate that one. And I give you a list for that one. So your familiarity, like example with the tuning for your familiarity with a monofilament, your familiarity with this and that, blood lancet, whatever the thing, they will like to check that one as well. All right. In Zoom-based exam, this part is not always that necessary, but you have to tell if any instrument, I repeat that one, if any instrument is in use for the physical examination and you're explaining to medical student, you have to know about that instrument well. I repeat, you have to know about that instrument well. Right? So this is the thing. If it's a tuning fork, you have to know tuning fork now more. So a little bit more information required probably about the instrument, about the Zoom based exam, because you have to tell somebody this is tuning fork used tuning, like no, it's tuning fork, this is used for this purpose, this is used for neurological, the sensory things, plus there would be like say ENT examination, Remus Weber's is also can be used. So those additional information you have to really make him understand that he's like a he does not know anything. You just have to make them understand. Okay, so understanding the the instrument well. This is one of the point. Understanding. So many are very smart. Okay, oh hey, see this is tuning for these people like very smart. This is not the thing they're looking for. This is they also know the right information at the right moment to medical students. They are not up to the show. Just see your smartness, fluency of English, not to lose that. Of course, it's important to finish the case in time. All right. Next would be commentary to the examiners. Actually, in the real life examiner, like with the examiner PFE, how you're interacting, that also matters. But here, that's the one of the new update that because there won't be any examiner there. There won't be any examiner there. So this is one of the point like which we need to be careful. Next is coming like answer to the examiner's question, answers to the patient's question. Zoom based examiner won't ask you, or invigilator won't ask you anything. But in the main exam, examiner some cases step in. They might ask you a few things. So, doctor, what's your diagnosis? Because it might be he might be trying to save your time, right? So these are the some points actually. And also, patients does have inquiries like, if, for example, if it's a surgery, what is the percentage of success rate of this surgery? This kind of weird question. Also, you have to answer smartly. Okay, so what do you think, doctor? What is the chances of my survivability? It's very normal for a patient to ask this sort of question, right? So if any surgical thing is involved, please remember this trick. If surgical thing is involved, go to Google and just search about the procedures and the success rate. Adding these things make your cases more stronger. These are secret things in the examiner's list. All right, the no, okay, this doctor has additional information, and this will make your patient more confident for the surgery. Okay, so 5 of this domain. So it's all together, but you might be asked about 3 or 4 domains, or some cases 5 domains. Okay, so it depends. Not all you will be judged. You'll be judged on the 4 or 5, right? Because many time management is not there. Many time history is not there. So these are the few more points here. Anything you like to ask, my dear doctors? Anything you guys like to ask here? Or otherwise, I'll move forward. Yeah, please participate in the comment section. If you want me to move forward, please also write it. Yeah, participating is good, right? Any questions? Okay, we'll move forward and we'll see actually. Move forward and we'll see what coming up next. All right, okay, back directions. Okay, so this is how the things are given, like mark sheet are given in that way. I hope you've seen some of them. Like one is a clear pass, fail, clear fail actually. So anyways, we don't want to be in this too in any way, isn't it? We want clear pass. Yeah, that's the thing. All right. Now here you go. Have you ever seen examiner sheet like that before? I mean, unless last day I show some of you guys what is with an examiner in the MC clinical exam. This is the thing which they have in their hands. Now, if you see for a while, uh, pass, I mean, very satisfactory or clean pass, satisfactory pass, unsatisfactory. So all of them has some points actually, which I think I explained in yesterday class, but everything has to be very perfect. You see this thing, initial approach, technique of examination. These are the things it's included here. Accuracy of your examination included here. DD and diagnosis here. Initial management of your plan. So management initial of your plan, they are giving a lot emphasis. So what you are going to do for this case is very important. So that one carries a mark. Answer to the examiner's question. So they will mark you in that way. So if at any point, if it was very good, they will mark you here. And the another one, answer to the role player's question. If it is not good, they will mark you here probably. Okay. Then finally, the thing comes is a global scoring, right? I mean, they will count all together that, is it possible to make this pass? So many times you will find in different components like 4, 4, 4, and 3. Usual cases, you'll get 4 components. So 4, 4, 4, 3 out of 7 they counted. So 7 by 4, 7 by 4, 7 by 4. And one you get my 7 by 3. Then the thing that matters is the global scoring. Are you, perfect throughout in that case? So in that case, this is small one, they might ignore actually. Yeah. So I'm not sure in the online what they're doing, but probably they are not giving you benefit of doubt probably in that case. Okay, so this is one of the point that is maybe the reason the passing was not up to the mark actually so far. But I think with time it will be fine, and many candidates are puzzled. I believe online is not comfortable for so many. So those of actually went for the exam, uh, maybe have taken tuition, over face-to-face classes. They don't have the training online and the thing. So it's very natural there for them to get puzzled if it's online based exam, because suddenly if you just practice 1-2 times and sitting for the online exam might put you in trouble. So here's a good thing, those of you who are with us for last 3-4 months actually, I mean, be confident. I believe you guys can do much better than those take the tuitions face to face sometimes, because you are more adjusted to Zoom based exam and it's role play, right? So these are the things. So or for the others, they can do more practice with your friend, more having a screen, more you should have a webcam. There's many doctors are practicing, they don't even have a webcam. All right, so this is like not right. You should have a very good quality webcam. Logitech is a good one. Logitech 1080. Buy it for MC clinical exam. All right, so for the cases of cardiology, start going to follow some of the books as you guys can see. Uh, Handbook Clinical, Marwan, Karen, McBullets, RSCGP, some of the guidelines might be used here sometimes. John Murtak, 7th or Patient Education 8th, those are some of the books can be used at any certain point. See, patient's question you can see from John Murtak, Patient Education. Patient's question, it's not the same John Murtak book. John Murtak has 3 types of book. One is the main book and one is the patient education. There's another book available. So patient education you can see for the, what question you might be asked. Okay. And also some classical we're going to see, and also some of the new ones we're going to see. All right. So next slide, actually, let's go forward. All right. And one more interesting information, that failing rate is, it's unfortunate, that's 80%. I'm talking about the main Melbourne NTC exam. I don't just judge for 1 month the NC online exam by Zoom. I hope so it will increase with time. All right, next. But you should also know that 20% people also do pass the exam. All right, any exam you go, like passing, failing is there actually. So I don't want to bother you with the word that failing is the pillar of success. So but it's not like that. It's a very expensive exam. No one wants to fail first of all, but it's not end of life. If it happens with any one of you, it's not the end of life. Actually, you just move back, just be focused. You will pass next time. Actually, so that's the thing. So 20% is the passing rate official. It's given in some websites and the thing. So it might vary from month to month, online based, and those other things. Yes. All right, few facts. This is some of the things you guys might be want to know. Some facts about Zoom based exam. All right, so do you know that Zoom based exam takes almost 7 hours, 7.5 hours to finish? Answer is a yes. Why? There's a lot of security check. There is a rest station. Then there is like breakdown rooms. Yeah. So there's another thing, breakdown rooms actually. So it takes a lot of time for security and the things to start the thing. Same 16 station, 4 of them are rest station. 18 are the number of candidates who attended at a time. At a time, 18 slots out there. So 18 slots, 18 candidates appearing. You guys can also see each other. While you are in the breakdown room, you can also see each other. One common rule, you cannot turn off your microphone. That is like a penalty. Repeat, at any certain point, you cannot turn off your microphone or your video. Question, are you allowed to go to toilet? Yes, definitely. Are you allowed to take food? While you are in the restroom? Yes. Okay, so these particular things are there, but your screen and things has to be there actually. So all the the things are similar, just little new adjustment. All the things are quite similar, just there's some little new adjustment. One of the adjustment is in the physical examination. So changes, so no direct PEFE to the examiner, physical examination finding to examiner. Rather, in the slide of your screen, at a certain point, the physical examination notes will be given, like physical examination, these are the findings. And another cases you'll find, please explain this condition, this physical examination to this medical student. All right, so these are the two updates on the physical examination. All right, a few new information. Role player, normal exam, role player visible, examiner also visible. I mean, in my visual acuity is visible, not in front of me in the main exam. A Zoom-based exam, role player is visible. What about examiner? Examiner remains invisible. Invigilator remain invisible. All right, so these are some of the key points. As I said, time to time I will update you guys more, and we'll see. Next is coming. Okay, it's the same one. Okay. I mean, since cardio is starting, I'm giving you a little guide actually. Especially some new doctors also keen to learn few things, especially before you start talking about the approach. Some examiner sickness like, who am I? I mean, you don't have to ask that one, but you just clear your position. You should know yourself. Also, let the role player know that what's your position, GP, intern, or junior medical officer actually. Where you are, I mean, so this is I'm Shahriar, like one of the junior doctor of this hospital. So if it's a rural hospital, then the thing, I mean, make it clear sometime. Yeah. What are the problems actually? So you rule it out. What brings you to the medicine? Is it an emergency? Please, I mean, your assessment, whether you understand the reality. I mean, if you are going with the case, they will think, you are thinking in as elective case. If you don't ask about the painkiller, if you don't ask about the vitals in the beginning, they will think that, you are failing to assess the emergency. If it's a chest pain, which is the emergency case, if you don't ask about these things, so that's like a penalty here. So casing, those are important. So what are my tasks actually? So always stick to your task. So know about that one well. What's your task? So that's very, very important. Sometimes examiner in previously, used to instruct us, stick to your task actually. Okay, sometimes, and now it's not given. So these are some of the basic differences which we got. All right, so a few of the things that might clear you guys even more. How to approach, as you guys can see here, especially. So as you guys see, greetings, ID check, smile, sanitize hand, introduce yourself, vital assessment, offer painkiller, take to, cubicle if it's required. So two things I wrote, if it's required, like vitally unstable, take them to the cubicle. This is for the real life exam. Role player is visible, examiner is also visible. All right, so these are the certain points. Next coming is a point, approaching to the Zoom based exam. This is how it looks like, right? The screen and the things actually. So thing is, all the checks are there, like you don't have to sanitize your hand. You don't have to sanitize hand. So there's a cross for that one. Examiner visible, I give a cross. See the screen, so some cases they might not see some little examination finding and the things. So you can carry a A4 size paper. You can start writing once the exam is started. Before the exam is started, you can't write anything. I repeat, before the exam started, you can't write anything. Once the exam started, that 8 minutes, you can write, you'll have a pen paper like that. And you have to do security check before the station is started. All right. Any questions from my dear doctor? So far, is it helpful? So far, is it helpful? Some of the new features, guys. As I said, those I'm trying to tell. So little feedback from you guys will be appreciated. Come on, guys. The
Yes,
tutors
doctor,
also
very
need.
helpful.
Okay, thank you, doctor. I hope so. So time to time, I'll give you more things. We have 3 cardiology class. So in 3 different classes, I will give more updates. updates to you guys. So this is the first installment updates. Some of you know these things. I think in the second or third class, I'm going to also show you how to do the examination with the, especially to a med school student, how to examine it in the right way, in the right proper approach. I will also guide you guys on that one. No worries. All right. So here we go. So going for the next page. Sorry. So the basic differences you guys understand. So MJ Clinical going to start now. I think Dr. Faiza is going for the first one. So I want Dr. Faiza to come to in front of me. I'm going to also be available for you. So be ready, Dr. Faiza. And before that, I'm just giving them a little time. Cardiology cases, guys. These are the two cases we found about the cardiology: chest pain, MI, angina. These cases, syncope. These cases. So you can just took the page. I mean the things. Of course, I'll give you guys the notes, so don't worry. But if anyone is just attending trial, maybe you can take just a small note. So for the cardiology, the MI and the syncope. So these are like the page numbers. Often we ignore the handbook, but we should not ignore it. So these are the relevant, handbook cases for the first class. Now, all right, so giving you guys little idea about the what cases you need to cover for cardiology: classic cases, new cases. Wrong approach, only reading new cases, wrong approach. Reading classic cases and new cases, right approach. Because you don't know what is coming, right? So that's, you all need to know. So classic case and the new case, that should be the right actually. Only, that someone is going for new cases, wrong approach, right? Now that's the thing. If you see with a case of chest pain, it does come almost every year. 2021 you'll find, 2019 it find, 2020 I think very less cases. Um, so chest pain related, you might find shortness of breath. Sometimes chest pain and shortness of breath also mixed up in some cases. So it's very important you rule out how you're going to approach actually. Next thing is coming, like there's a angina cases and underlying anemia, this thing, then this heart failure cases. So these are the some of the cases that can come. These are the important cases actually. We have seen coming in last 3-4 years. A very important other than chest pain, very important other than chest pain is a syncope case, which might be tested as vasovagal, recently we have seen, and also the postural drop, the proper drug history and the relevant history you have to take. I'll guide you guys on syncope in the second class, right? So the syncope will come in the second class. Then prolonged QT, that means belong to heart block, palpitation, some of the tiredness. So these are the another um, important slot cases. Another important slot cases. The tiredness, it looks very small tiredness, but it can be taken into any direction. Infective endocarditis and hypertension, and as I said last year, we'll also go with new case. Time to time also, in every class I'll also talk about new cases, but separately I'll be telling you guys more about new cases in the third classes if there is anything will be available. So these are the, in general, this will cover almost everything in cardiology. I hope so I'm not missing anything. After, I mean, if there is anything new, as I said, number 11 will be covering that actually. All right, so are you feeling confident? I mean, Dr. Faiza, I mean, seeing the cases? Okay, no worries, your turn is coming up now. And sorry for keeping you waiting, Dr. Faiza. Few ECGs you guys sometimes need to cover because relevant ECG. Now that's a common question to me often I got. Doctor, which exact ECGs that sometimes comes in the main exam? So that this is the list actually. So MI, the chest pain, pericarditis, any palpitation can come as a case actually, or sometimes we ask, is there any office test available? They give supply you the ECG, that will be the ECG. And also electrolyte imbalance, hyperkalemia, case might be there. So these are the ECG cases you need to see carefully for this MC clinical. Next would be coming some radiology. So some radiology, which radiologists? We have seen supplied congestive heart failure. We have seen supplying some radiology related to pericardial effusion. So please keep it in mind for these two cases. Other, don't bother much. So heart failure, you can understand this, like, heart size and the things that can be important. The pleural effusion pneumothorax going into the respiratory. That's why I didn't bring it here. I'm talking only about the cardioradiology. Cardioradiology. All right, that's the thing. All right, before we start, okay, sorry, Dr. Faiza, I'll keep you wait for a few time. Some chest pain relevant cluster or DD. So I'll give you guys some guide how to approach to cardiac cases. Let's say this is the chest pain case or a DD or a cluster. Whenever, if I ask you guys actually, so now a little participation will be expected from everyone. I mean, let's play again. What are the cardiac causes of chest pain? Okay, let's ask one by Dr. Natalia, if you want to tell what are some cardiac causes of chest pain. Others free be in the line as well. You can also comment, start commenting, guys. Dr. Natalia, you can try. If not, like Dr. Faiza, Dr. Ipa, anyone.
Cardiac cause, it can be pericarditis, aorta dissection, and unstable angina, and myocardial infarction, and myocarditis.
Myocarditis. So you include the cardiac, and also those aortic causes are also somewhere. It looks like a central chest pain. So it's good that you said that one. So these are the cardiac causes of chest pain. Thank you so much for telling that one. Dr. Faiza, what do you think about the non-cardiac cases of chest pain? Other can pass an answer. Other can also pass an answer. Anyone unmute and answer?
Like GIT cause, like GRD, critical set
Excellent.
disease.
Yes.
Like
So we actually think GIT respiratory. Like I give you a tip, just after cardiac, think as GIT respiratory. Respiratory are the peripheral chest pain, and the ZRD also gives guys similar like that kind of vibe, right? So good. If you say those, very good. Well done, Dr. Sylvia. Okay, so next one, I mean, I'm just going to show you that some of the cluster. Cardiac clusters are like that. Myocardial infarction, angina, coronary syndromes, all these things, including that pericarditis as well, okay, so are included in this cardiac actually. Apart from that, you see there's a list of non-cardiac. Like aorta, you can also put cardiac number, that's okay. I mean, usually cardiac is exactly heart actually, but that's also okay. Central chest pain also, aorta is there, central chest pain, esophagus is also there actually. The respiratory causes, these are kind of like big peripheral chest pain. If you see Davidson, central and peripheral chest pain, just like that. Exact cardiac one are more like a central and little left-sided, Those are the more like the cardiac pain. And effort intolerance and more things, when you will see in the history and we'll get to know actually. But these are some of the other non-cardiac chest pain. It's easy, I mean, other than just going one system, cardiac, non-cardiac, cardiac, non-cardiac. There's a one case also came as interesting. Herpes zoster can gives rise to chest pain. Please remember that one too. Okay. So aorta, esophagus, respiratory GID, aorta, esophagus, respiratory GID, and finishing with infection, herpes zoster. So these are the non-cardiac causes of chest pain. All right. Now, when we take some idea about the DD and the thing, central chest pain emergency, it looks like, other than the MI, it can be this CRD thing. Other than that, it can be also pulmonary embolism. Because ruling out the emergencies are very important. Because why? Because patient might die at any moment. So it's very important you rule out those things. So here's some DDs are given, as you guys can see. I'm sorry, I'm taking a little time today in the basic because it's the first class on the cardio. I'm taking a little time to explaining the basics. So starting with the very common question, we give open-ended question. After that, key question comes like, is there any shortness of breath, racing heart, any sweating, any associated factor? Is it radiating? Is just staying here or radiating to arm, jaw? Because you're thinking about MI pain radiates more. Then pericarditis pain, so keep it in mind. Pericarditis pain, if you, okay, that's an interesting point actually. Who can tell me pericarditis pain apart from the central chest pain. What additional key points out there? Pericarditis, apart from the central chest pain, what additional point would help you rule out? Anyone? Very quickly, come on, guys.
PFE, pericardial rub,
Rub is okay, but clinically,
recent upper respiratory tract infection,
not that one. I'm looking forward to clinical feature. Some other, please.
Pain,
Someone
Pain on
other.
respiratory,
inspiration.
Position.
Pain on inspiration.
Pain on
respiration.
deep inspiration. Yeah, pain.
Yeah.
Correct the word. Pain on deep inspiration. Yeah, because inspiration means I'm also taking inspiration. Pain on, like deep inspiration. Deep inspiration causing pain actually. One more. One more. Similar like that. One more point.
Pain
Positional?
on leaning forward.
Leaning forward actually. Okay, so there'll be more pain on leaning forward or lying flat. What do you think?
Both, I guess.
Both,
Line.
yes. Yeah, both is correct. All right, so these are few. So position changing. So point is what? The position changing is causing the pain. Position changing is causing the pain. Lying flat causing more pain. Lying flat causing even more pain. That's the thing. So position changing is causing. So this is some of the very interesting. And ECG wise, if you go, ST elevation in MI, reciprocal ST elevation, pericarditis, diffuse ST elevation, and downsloping TB. These are some of the additional points. Aorta, you will have to take the proper history, Marfan, if there is a history, any trauma history, and this kind of thing. Aortic stenosis, extreme elderly, chest pain, shortness of breath, and the syncope thing if it is there, along with that or not. So I have to see. And of course, what additional point I need to look forward in physical examination in aortic stenosis? You guys tell me. These points, other than one special physical examination finding in aortic stenosis, we'll tell quickly. Come on, Dr. Saman, you want to add any point?
Muffled heart sounds.
Okay, almost there. Muffle. Okay, I'm thinking more about the cardiac
Pericardial
component.
rub. Pericardial friction rub.
No, I'm talking about aortic stenosis, dear. A friction rub goes with, I mean, that goes with pericarditis. My question was aortic stenosis.
Ejection murmur at aortic region.
A murmur. Yes, that's the point. Yes, well done. So that's the point I was looking forward. Murmur. Maybe one doctor had different actually. Yeah, so maybe I had pericarditis, but that's all. That was also correct for pericarditis. But murmur was the point actually I was looking for. So aortic stenosis, apart from these features, extreme elderly, chest pain, shortness of breath, syncope, and that murmur. That's important. A2CM, runs in the family, autosomal dominant, sudden syncopal attack, history of death in the family before 50. These points are important actually, ruling out that actually. All right, and of course the pulmonary embolism. Additional point, you can see any recent travel, any clot, or any drug, these things. There's any recent surgery, prolonged bed rest, and a lot of points you can add for pulmonary embolism actually, which we'll discuss. Don't worry. One more important information. Any chest pain suspected MI until proven otherwise. So your guideline management for any chest pain, the examiner should have that feeling that you are keeping that MI in your mind actually. Then you are trying to exclude the other. So any chest pain suspected MI until proven otherwise. Well done, guys. Like you did good job. So let's go to the next page to. Going to the next page. Yes. So also ZARD and this sort of things, you have to find the person is obese or not, and you take the history of bloating and the relevant thing. And if there is night symptoms, I repeat, night symptoms. So those ZARD, pancreatitis, pain, radiating towards the back, epigastric pain, radiating towards the back. All right, trauma history, malignancy, some cases psychogenic also. I find a case, look back, the patient goes, oh, I'm having heart attack, things turn out to be, psychotic case. So, just keep it in mind. And any recent history of viral infection, that will exclude what? Any recent of viral infection, exclude two things. What are those two things? One, you can see it's evident like pericarditis because Coxsackie virus is relevant. What is the other one? There's the other virus that can also cause some issues. We actually look forward to herpes actually, isn't it? We actually look forward to herpes actually, yes. So pericarditis, so any recent viral infection, maybe a pericarditis, maybe herpes. Then we'll exclude by, the patient lying flat causing more pain, deep inspiration causing more pain. Those will be the additional feature actually. In the beginning history, we always, when we take the history, like if it's a chest pain, we started with Socrates, right? We start with Socrates, then we take the proper history and the thing, we ask about associated, relieving, blah, blah, so many things. Then we finish up with past medical history, then we ask about family history, then we ask about SADMA. If it's obstetric cases, then the more birth history and things are there, right? So these are the few points which you guys need to know. And apart from that, must consider for our case or any central chest pain cases, like MI or angina, sorry, the second one I should do, angina, CERT, then herpes, postochondritis, aortic pericarditis, and these points actually. These points are more valid points. Earlier I show it's just the basic one, but these features you should definitely keep it in mind actually, especially if DD comes, please explain the DD, differential diagnosis, to the med school student. These are the points you cannot skip in that case, because chest pain is something very important. Okay. So going for the next one, I hope so it's quite clear now. And when it comes taking history of a chest pain, that comes with the Socrates actually. Socrates, I'm sure, are you guys familiar with Socrates? Guys, are you guys familiar with Socrates? I hope it is yes. Like, you see, site, O for onset, C for character, radiate, associated symptom, time, exacerbation, severity. I'll try my best in my way. Okay, let's see, give a try. Okay, say I'm the patient, I'm trying to explain. So, the ideal history, okay, say I'm a doctor, I'm trying to give a history. So, sudden severe compressive central chest pain, sudden severe compressive central chest pain, which radiates to the arm and jaw, which associated with profuse sweating and some breathing issues, and maybe decreased heart rate. And it lasts for more than 1 hour, which is not relieved by any sort of painkiller. And it is getting worse with time. Now you see what are the points I said. Did I cover the Socrates or not? What do you think, guys? Did I cover the Socrates? Sudden severe compressive chest pain, the character radiates associated. So you need to practice, guys, because even if I ask someone of you, you might skip one of the point, and this is the area they sit to cut down your point actually. Okay, so this is the way to practice, especially not skipping major points. So these all are the major points actually. Clear? Socrates clear? How to start the pain history? Is it clear? I hope it is clear to all the my dear doctors. All right. Okay. Before history, any cardiac cases before history, here is something you should do. Here's something you guys should do. What is that? Are my patients vital or stable enough to proceed? Ask about vital. If unstable, so DRS, ABCD actually. All right. It means actually that taking the person to resuscitation cubicle. Okay, taking the person to the resuscitation cubicle. Then make sure that ABC is getting. Then it also includes drug, that painkiller, and also educate the person. All right. So these all things I think which I told earlier, not asking about the vital, and please be smart on asking the examiner, dear examiner, I want to know about the vital of my patient, starting with blood pressure, pulse, temperature, respiratory rate, and if there is any saturation, you can, if it's available. So the examiner will be very happy to quickly proceed with you. Otherwise, the examiner to know the vital of my patient. Okay, what do you want to know? See, this is killing of time. Rather than skipping that one, and you can tell, my dear examiner, I want to know about the vital of my patient, starting from the blood pressure, pulse, temperature, respiratory rate, and saturation. Now he will be ready. He will be ready on telling about these things to you actually. So he'll be just quickly tell you. All right. By this time, We'll also ask the patient about whether he's having very severe pain or not. Rate your pain on a scale 1 to 10, 10 being the highest. Can we right now? Yes, I think I'm having 10 by 10 pain. So Melissa, do you want me to give some painkiller? I'm sure you know you're suffering a lot. I'm so sorry. I'm so sorry. See, another approach that came out from my mouth, again, marks given. Some people forget to ask that one. Someone not caring. Okay, so real life, lot of things that matter. I'm so sorry. This one word will make the patient pamper and make them more comfortable. Don't worry, we know we are with you and the thing. So these things are in sensible lot of marks out there actually. So when you start in that way, especially vital, especially painkiller, you pamper the patient, you give reassurance, you will get the full mark on approach I can guarantee. All right. So after entering into that, you know, there's few other points that came out, especially in the physical exam after taking the history. Some of the history part I've shown, you know, initially the emergency assessment, then comes the history part. We start with Socrates. After that, past history, family history, negative history exclusion, past history, family history, right? So those things we try to exclude. After excluding those things, then we come to the physical examination. Especially we start with pickle. During examination, I want to know about the vital of my patient. Initially, I want to know is my patient is as stable as before. Please mark my word. Is my patient is as stable because you asked initially. Is my patient is as stable as before? Yes, stable enough to continue. Okay, I also like to know about is there any pallor? Is there any icterus? Is there any clubbing? All right, is there any colonoikia? So negative for all. Any lymph node enlargement? No. Any edema? If it's a heart failure case, yes. Now we'll go for, is there any edema in the other dependent parts? I also want to know that, like leg, behind the sacrum, yes. Then comes T for what? This T for what, guys? Pick out. This T for what, guys? Who can guess? This T stands for what? General appearance. Dr. Kaihan, what do you think? Sorry. Yeah, thyroid. This one goes for thyroid, not temperature, because the temperature goes with the vital, which we asked already. This one is thyroid. Now, the question is coming, why I say rather than pickle, I make here pickle? Who can tell? Why thyroid is important to me in cardiac cases? I repeat, why thyroid is important to me? Thyrotoxicosis, atrial fibrillation. Yes, that's the point. Well done. So apart from that one, this general appearance and the thing, then vital, like these things, especially blood pressure measuring. I also want to know my patient's blood pressure in both positions, standing and sitting. Is it same before? Yes. That means not a postural drop. Is it same? Yes, same. So that's why we differentiate posture. But if it's standing, 130 by 90, and in the sitting position or lying position, if it dropped maybe 120 by 80, that means it's changing. So that information is very, very important. Ruling out postural drop, because postural drop is an important cardiac case. Also pulse, very important. You should also ask separately. I mean, other areas you don't need it. Cardiac cases, you separately, if it's possible, like especially in the pulse. The examiner, I also want to ask, is the pulse is regular or irregular? He's liable to tell actually if it's the center-based exam actually. I repeat, if it's a Zoom-based exam, it will come directly. As you guys see, this physical examination, this will come in your side. Now, if you have a very small screen, it will be very tough for you to see like that. Okay, so they'll give the positive finding and that particular thing. So you can see that one. In the cardiac cases, S1, S2, any murmur, aortic stenosis murmur is important, or any added sound, like they will say yes, there is some noise present. That means pericardial drop. They say it as a noise. Okay. Respiratory is bilateral equal. Now, why this is important for us? Is it bilateral and equal with sound? Bilateral equal. What chest pain thing I like to rule out here, which is very, very important for me, ruling out. Bilateral equal. Some cases, one-sided breath sound is affected. So I'm trying to rule out what case here. No, not aortic dissection,
Pneumothorax.
one-sided breath sound, pneumothorax or hemothorax. If there is trauma history and the things also there can be pneumo or hemothorax. We can rule it out by a percussion rod. Hyper-resonant, the pneumothorax. If it's dull, it's a hemothorax, right? But breathing sound, that is affected in both cases. Breath sound affected is one of the particular side. So bilateral equal will gives you idea. This is not those respiratory pneumothorax. So you are ruling out one more important DD. Is it clear, everyone? One more important DD. When you just ask like, is the breath sound is bilateral equal? You say yes. Your pneumothorax ruled out, full mark. All right. Next comes some of the thing: mass, tenderness, reflux, ascites, which we also check by going to the abdomen. A few of the things like congestive cardiac failure, which might have a dependent edema, including this anasarca possibility, and also the reflux thing. If I press here, if I press the abdomen, is there any jugular venous reflux? If I press the abdomen, is there any jugular venous reflux? That goes with congestive heart failure ruling out. Last but not the least, finish your, physical examination. Is there any office test available like urine dipstick, blood sugar, ECG? You have to tell these things. You cannot just tell, is there office test available? Otherwise, they also what do you want to know? Urine dipstick, blood sugar, ECG, any spirometry, or anything else available. Then your question would be anything else available. Any radiology available? Ask him. It's your right. Yes. So that's the thing here actually. Anyways, and don't forget to ask about the blood pressure in both arms. Blood pressure in standing, sitting, blood pressure in both arms. Additional will give you more marks for that. Additional will give you more marks for that. Okay, you can also ask one more thing, just my tip, that one for you guys. Is there any rashes or any chest infection? No. Ruling out what? Rashes or chest infection? Ruling out what? Because that's one of your case actually in the exam. Yes, please.
Herpes zoster.
Yeah, that's a herpes actually. Yes. Any rashes and chest infection. Rashes and chest infection, ruling out the herpes. Herpes with there is a one case present. So when you just ask that one or mention that one, that will be enough. I'm telling the both because there's a lot of also doctors even in our academy. Few also booked for Melbourne-based exam. So we just cannot tell the Zoom-based exam here actually. All right. Okay. So as I said, physical examination, this whole thing, what you are seeing right now, will just come in a corner. Your question would be there. Also, this would be there. Now, what will be the problem? You have to just come like this to see that one, right? So this is a tip. Try using big size monitor. So my screen is a 16-inch. It's quite a fine enough, I'm telling you. If you can use the 21-inch monitor, that's best. Don't please use 13-inch monitor. You will have real difficulty in the whole one. Already stressed because of the screen more stressed. Okay, just be careful. Buy Logitech webcams. Buy Logitech webcams. Otherwise, what? Otherwise, you have to take the whole device and show the room like that. If it's a webcam, you just can show like in that way very easily. All right, so I'm just switching. That's very easy. If it's a desktop, even more difficult. Like some desktop have inbuilt, camera, so even more difficult to move that. One more information: those are living in Asian countries going to take your exam. Should I give this internet suggestion today? I guess let's keep it for the next class. There's a few things I should keep. So there's some very important internet update and issues. I'm quite tech expert, so I'll tell you that suggestion in the next class. You have to wait for that. All right. So that's a huge thing, that internet thing. It's not that easy as we're thinking. Because almost everyone, I think 30–40% is suffering with internet. So how to tackle that one, I'm going to tell you in the next class. If you're in Asian countries, it's very important. As yes, some few things in Australia. I'll tell about that one why. I'll tell about that one why. First time when I visit Australia, I felt terrible. And many students are laughing. Doctor, we used to tell you don't believe us actually in past that how come Australian was internet can be so bad. So I changed some maneuver next time. Then I don't have any issues. So I'll tell you that one, how to do that. Because usually the net is good. It's because of some device placement and a few of the things out there. All right, so that's one of the thing, and consider some investigation and workup, like including ECG, cardiac markers, X-ray. These are basics, so including the CBC because infection could be there. Electrolyte important because hyperkalemia can be there. Echo is important. I want to check the heart valve, cardiac catheterization, D dimer because pulmonary embolism, and helical CT and so on things in also. So these are in total that investigation. If you add them, you will never fail in the investigation part. Actually, better not to miss any of them. Yes. So who is getting ready? Dr. Faiza, is it first one? How right?
Yes, sir.
Okay, so you can come to. Can you be visible if it's okay with you? All right, so Dr. Faiza is here. Okay, so there's a lot of views. You guys can also change views in the Zoom. So I'm also visible. I guess Dr. Faiza is also visible. Yes. So I can see Dr. Faiza. Yep. So you know the deal, Dr. Faiza. So basically, I'm going to show you the display of the role play, and you'll get 2 minutes. You have to read the instruction clearly, then we'll go for the role play, right? Let me just show you the screen. Oh, I'm so sorry. Here you go. Here's your case. I hope you can see. Your 2 minutes starting now.
Because of the timer, I can't see the last portion of the.
All right, I'll do it myself. I'll inform. This is important, guys. See, Dr. Faiza, speak up. You all can always speak up. There is a IT team. This is one more information. We'll talk about that in next class. There is a IT support in the main exam. Just to advise. One information, guys, you can always drink water in between the breaks. Make sure the bottle you are carrying, that has to be transparent. Like in my one there is a lot of labels are given. It's not allowed normally. It has to be a transparent bottle. All right, we're about to start the session. So Dr. Faiza, are you ready?
Yes.
All right, you can start your case now. Will let me know. I know when you are ready.
Okay. I can start.
All right.
Hello, examiner. This is my ID.
All right. So it looks good actually. So you understand your case?
Yes, I understand. May I know if my patient is vitally stable?
Okay. What do you want to know?
May I know the pulse, blood pressure,
Pulse is,
oxygen saturation?
currently. All right. So pulse is 90. And blood pressure is currently 140 by 90. Temperature is 98.4 degree Fahrenheit, and temperature, yeah, as I said.
Oxygen
Anything
saturation?
else? Yeah. Oxygen saturation is
Okay,
currently 98.
thank you. So I'd like to proceed to my patient. May I know his name?
His name is John.
Hello, John. I'm Dr. Faiza. I'm one of the junior doctors in this emergency today. I can see from your case notes that you've been having chest pain for the last 1 hour. Can you rate the pain on a scale of 1 to 10, 10 being the highest?
Doctor, actually, I'm not feeling so well. Doctor, actually, it's like, I would say it's like almost 9 or 10. So I'm so sorry.
Okay, I'm very sorry to hear that, John. Let me take a moment. Do you have any allergies to any pain medications in the past?
No.
Okay. Okay. I'd like to ask my examiner to shift my patient to the emergency cubicle and I'll give him, put him on propped up position and high flow oxygen. Also, I'll hook him to a cardiac monitor and ask my patient, my nurse, to do an ECG. At the same time, because he's in so much pain, I'd like to give him a dosage of morphine with antiemetics.
All right. Yeah, his pain is relieved now. We can proceed with the case. Thank you.
Thank you very much. So John, may I ask where is the pain exactly? Can you point with your finger?
Yeah, doctor, actually, yeah, it's just in the centrally, and it's been started like since last 2 hours, and I can tell you, how severe it was, and I was feeling like almost I'm going to die actually.
I'm sorry to
Die.
hear that.
Yeah, so and then suddenly my wife was nearby, and I just called, and she just quickly picked me up actually. So that's why we are here actually.
It's very good that you came in early. May I ask, is the pain going anywhere from your chest? Is it going to the left side or the right or back towards your
Yeah,
jaw?
I feel like it's going in my left shoulder probably, maybe down as well. Yeah. Mhm.
Anything that improved the pain, any particular position, if you were sitting up or
So because I feel like when I was coming down through the stairs, the pain was increasing. Yeah, my house is on the 3rd floor, so we don't have the lift actually. So when coming down, it was feeling more bad actually. The
And is
painkiller,
this the first time?
I took the some Panadol and some painkiller was present at home for some other purpose, but it didn't relieve my pain actually.
Glad to hear that, John. May I ask, is this the first time you're having this type of pain or has this happened before?
No, I mean, not this kind of incidents. I do have, you can see from the chart, like hypertension, cholesterol, all these issues, but
Yeah.
this kind of, I can add one thing. I was feeling little, different in last week actually. I mean, in the morning I take exercises and the thing, how I feel every day. I mean, for last 1 week, I was not feeling that good actually. So I was thinking maybe something bad happening, and suddenly it's just started. Yeah.
Okay. May I ask, have you had a fever or any cough recently?
No.
No, nothing like that. Any nausea, vomiting?
Currently, I was feeling little nausea while coming back. Now I'm feeling well.
Okay. Any dizziness or any blackouts?
No.
Have you had any sweating
Thankfully,
during?
thankfully not. Yeah, no. Yeah, I'm feeling. I mean, when the pain started, I was sweating a lot. Yeah, thanks for asking that. You know, when the pain started, I was sweating a lot.
Okay. And have you hurt yourself recently in the chest? Any history of trauma or accidents?
No.
No. No. Okay, that's fine. Have you noticed any swelling of your legs? Any calf pain?
Swelling? No, not really. No.
Not really. Okay. And
No calf pain.
no calf pain. Okay, that's fine. May I know, have you had any surgeries recently or in the past? Any other medical illness beside your hypertension, high blood cholesterol, and diabetes?
No. I mean,
No.
these are the. I don't want more. I hope. Yeah.
No, that's fine. That's fine. And have you lately been on a lot of stress? Would you say
Yeah.
that you're
Because of my business and
anxious for
certain
some?
things. Yeah, because of business and there's a lot of personal issues going on. So I was in stress. I won't deny that.
Okay. Any travel history recently? Have you taken any long flights
No.
recently or last week? No, nothing
I
like
think
that.
after the lockdown started, I think I haven't gone anywhere.
Okay, that's fine. I can see that you had a history of bad indigestion. Any heartburn or any other issues like that?
Actually, one bad indigestion is because there's a buffet lunch, I guess, that might be causing little problem actually that time. Yeah. But
And do
that
you
time it was
smoke?
relieved. Smoke occasionally, actually, not that regular. Yeah. Smoke
And do you
alcohol like
consume alcohol?
occasionally.
Occasionally.
Yeah.
Okay. Okay, I understand. So thank you so much, John. You've been really cooperative. I'll just take a moment to talk to my examiner, if that's okay.
Sure.
Okay. Dear examiner, may I know if how's the general appearance of my patient? Any signs of pallor, cyanosis, clubbing?
All these are negative.
Okay. And are the vitals same as before?
Anything else you want to know from general appearance?
Yes. I also like to know, is there any sign of dehydration or edema?
Negative.
And may I know the vitals are same as before?
Vitals are the same as before. You can continue.
Okay. Any irregularity in the pulse? May I know,
Pulse
is
regular.
there any?
Pulse is 92 and regular.
Regular. Okay. May I ask, is the JVP raised?
No raise in the JVP.
Is there any change in the blood pressure in sitting and standing position?
It's similar, like in both position.
And may I know the blood pressure? Is there any difference in both arms or both lower limbs?
It's bilaterally equal, the blood pressure in both sides.
I'd like to do a focused cardiovascular examination. I'd like to know if the apex beat is displaced, any trill present, any palpable P2, parasternal heave.
Okay. Apex beat is present in the right place. I mean, in the 90 degree space, 90 degree from midline, and there is no additional murmur or any kind of added sound. Actually, you can proceed with the next one.
Is airway entry equal bilaterally?
Bilaterally equal. You can proceed to next one.
Okay, and any other crackles or added sounds on respiratory examination?
Negative.
Negative. Any findings on the abdomen examination?
What do you want to know?
I'd like to know if there is any hepatojugular reflex, any tenderness.
Negative.
Organomegaly.
And balsam is present. You can move to next task.
Any office tests available?
There is ECG available for you. ECG is showing there is ST elevation.
Okay. Okay. Thank you so much.
Yeah.
Examiner, I'd like to order.
You can move to investigation now.
Okay, I'd like to order for cardiac markers, CKMB, troponin I. I'd also like to do a chest X-ray and a full blood examination, ESR, CRP. I'd also like to refer my patient for cutaneous intervention. And I like to check the electrolytes. Yeah, that's it. And order for chest X-ray.
What happened with me, doctor, actually?
So,
What's the
dear
diagnosis?
Mr. John, Mr. John, after taking your history and the findings are actually pointing towards a condition called heart attack or myocardial infarction. I'm sorry. Yeah. Okay, I'm very sorry to give you this news, but the good thing here is we have an excellent team of doctors here who will be looking after you. At this point, I'm going to start you on some specific medications. I've already started you on pain medications, and I'll give you some blood thinners as well as.
What are the differentials, doctor, for this case?
I have to still consider some other differentials. For example, in your case, it could be an angina, which is basically intermittent chest pain because of low blood flow to your heart. It could be gastroesophageal reflux disease, which is basically due to heartburn and indigestion. It could be other causes like a pneumonia, which is a lung infection, or air trapped around your lungs, which is pneumothorax. It could be a clot in your lungs, which we call as a pulmonary embolism. However, all those differentials seem unlikely at this point, given your ECG and the history that you've presented with. But still, we have to keep that in mind when we're doing the investigation. That's why I've ordered a few investigations to my examiner so that we can rule out those conditions.
All right, so you finish your case now?
Yeah.
All right, so thank you, doctor. So thank you, Dr. Faisal.
I don't know how to
yeah. No, that's okay. Now you took, I mean, just want to tell you the time. You took actually, overall you took 11.5 minutes actually. So that's okay. I mean, yeah, so flow was important. Sequence wise, that's sometimes it's better to go with, it's not always have to follow the order in that way. You can always also tell the patient that just to save time that, so from the history and the physical examination, and you can initially during physical examination ask about the office test. So ECG was already supplied. So you can tell the patient rather that, I think, John, in your case, we're suspecting myocardial infarction, but we also think there's some other condition it can be. But I like the way you discussed. I mean, the individually 1 point air trapping in your lung, so it can be this. This is a very nice move actually, and we also need to be careful that do you have time or not for that. So,
yeah.
But that's a very nice way of telling. It carries more mark actually because it's a case related to discussing the differential. So you explain that way, and then you can also tell. So, but we'll be more sure by ordering some investigation. Like then blah 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 blah. This you can also follow that one. You don't have to just bring it before that one telling the examiner. If it's mentioned in that way, appropriate investigation tell to the examiner, then it's you tell the examiner that one. Otherwise, think that okay, you have to tell this thing to the to the role player actually. So so total time taken is 11.5 minutes. Yeah, just to add that one. So this is the drawback. Otherwise, initially the flow was very good, maybe not as good as in the end. I could have tell the same actually. It's not good as the flow, I mean, how it started as the same. Another thing you said, like, doctor 2 times, Dr. Faiza, one of the junior doctor in it. So tell one time that particular thing actually. All right. Now, in a general appearance, you also forget to ask about the edema and dehydration. And also you didn't ask me about the thyroid. That's why I give a lead there actually. Anything else you want to ask? Yeah, thyroid, yes. Yeah, you do ask about the pulse, but thyroid is important here to ask actually. That's why pickled. And other time we use pickle. Pediatrics we use pickled. Okay, because dehydration is not
try to ask the dehydration or would be
so
just
D is more important. Yeah, dehydration is more important in pediatrics, so pickle, and in cardiology it is pickled, and P that comes for the thyroid. So remember now, from now on, everyone, pickle for general, pickle for pediatrics, pickled The T is for the cardiac, the T is for the thyroid actually. Anyways, you progress well. I mean, I'll give you feedback definitely on that one. So you missed some of those part, then your physical examination could have been a little bit more quicker. Okay, you could have asked a little bit more quickly. That part I felt that you lost some time in the physical examination. Same goes with the history. I mean, history you ask the general things, but there's a more easier way to ask and finish the things actually, like, you know, quickly you can move forward and more quickly in that part actually. But you managed to ask most of the things, including SAMA, including family history. I guess you didn't ask.
Oh, yes. Sometimes,
Yeah,
you know,
yeah.
when I see a big question, it's actually harder. Actually, in the main exam, it's going to be harder because you still have to remember a lot of information
Yeah.
that was given outside.
Yeah,
That
but a
he had
family is very
already.
important. You see cardiac
Yeah.
case. Cardiac case, not asking history. A pediatric case, you don't ask about history is a different thing. And a cardiac case, you don't ask about the family history because HOCM, angina, heart attack, all these things in the family. And also that should be extended asking that, and is there any early death because of heart disease? Everyone, please, those of you who are listening, you all should ask this question for all cardiac cases. Is there any early death in the family because of heart disease? Because that will be excluding some heart cases, that will be also excluding HOCM cases at the same time. Okay, so that's very important, that ruling out heart, not only just is there any family history, is there any death, early death because of the heart disease. Then you are specifying, that means you're specifying the heart diseases actually, right? So this is one of the point which probably missed in the history. So let's come and see. This part you did very well. This part you, I think, did quite well, offering the painkiller and the things. Yeah. Second coming to, okay, don't be afraid when you see too many history thing. Okay, so so deep down, if we see here, like Socrates, you tried involving in nice way. You did good part on that one, on the history. You went, you include travel, you include the associated also, that I like about you, like you include the you know, that associated history as well, past. You ask about one thing, very nice. Are you allergic to any painkiller? This is a very good thing while approaching. Must ask about that one. Okay, one more thing I like to ask all of you, because someone who is having heart attack, an elderly, all right, so um, when you ask, is there any past history or any past medications? So of course, I mean, might say no, but at the same time, there's a one more thing. Is there any medication you took recently, like, you know, aspirin, warfarin, or Viagra? So this is one more important, guys, to ask, because elderly person can use Viagra, and you know, that's another thing that causes actually narrowing of the arteries suddenly, constriction and the things. So it's a key one, guys. Please take your note. Actually, that will increase your marks, and of course, the family history, which might be Dr. Faiza might miss, might be an error. Let's see how it progresses with the time. Second thing that is coming, okay, with the SADMA, I think we all know SADMA is related to smoking, alcohol, drug, medication. Sorry about that, OSCE, and the allergy. So these are asked in very nice way, including the allergy has been asked in very nice way too. All right, so after the SADMA, then, you know, we went through the pickle. We have to ask these things in nicely. About usually we don't find physical examination wise that much significant thing. Rather, we try ruling out respiratory. We try ruling out other cardiac causes, like no murmur means not aortic stenosis or valvular heart diseases. No rub means not pericarditis. That's how we differentiate it. Any muffled heart sound means no cardiac tamponade or something pericardial thing. Any hepatocellular reflux means, you know, or ascites means ruling out the heart failure related things. Dependent edema, ruling out the edema related things. Last but not the least, when you ask about office test, I want to know about any office test, urine dipstick, blood sugar, ECG available. Okay, rather than taking more time, I repeat that one. How to ask: is there any office test available, like urine dipstick, blood sugar, ECG? So this is yes, ECG available. Okay, can I see the ECG? Or they will tell you the finding, either of the one. Okay, so this is how you need to proceed with that one. Afterwards, I mean, and as I said, Dr. Faiza missed the T. pickled. Actually, she missed also the edema and dehydration and this early part. She asked up to pick actually. So you all have to ask this. These things are important, guys. And also don't forget to ask about the pulse. You can ask directly, is there what is the state of the pulse, regular or irregular? You can be sure with the examiner, that's fine. Just be natural in the whole, like you're not talking to a person or a colleague or a patient. This is one to see that. Do not sound robotic. I repeat, nowadays is one thing told to the instructor. I know one to instructor, so is told in that way. If you found the person robotic, rote learning, scripted too much, you know, the global experience, they can, you know, just make it fail. Okay, so this is one of the points. So you also should sound natural. Actually, you should also sound natural at the same time. Smile, care about the patient. So when you do that, because that's not scripted, right? So this is one of the part. Second is, I'm so sorry. So the same thing, one suggestion, Dr. Faiza, nice case, but about showing empathy can be a little bit more empathetic. I don't know, maybe I'm having heart attack, so can be a little bit more empathetic. Okay, I'm so sorry. How you're feeling now? I mean, can we continue? Because it's a heart attack case, so we can do that. Are you feeling now? I mean, it's okay, I can continue. Please do let me know. Now, so this one little touch might case make the scenario a little different. All right, so that's these are the investigation part, you know, we just saw. Dr. Faiz also covered up, I mean, investigation well, like CG, cardiac marker, ECG, CBC, and those things actually can be done. D-dimer she didn't say, probably, yeah, D-dimer she missed actually, because but pulmonary embolism is important to ruling out. D-dimer I would look forward to see. So our diagnosis was acute myocardial infraction actually, or heart attack in general term. For patient who says it's a heart attack, doctor said the same. Do not use medical jargon. I repeat, do not use medical jargon. If you use it and then you realize, then just make it clear to them. Right? If you use it like in our word we call myocardial infarction, maybe you heard about the heart attack. I mean, in general term we call it heart attack. That way you can say the both. Yeah, so there's another smart move. If you accidentally, something slips out of your mouth, you just explain in the next while telling that one. Now it's a myocardial infarction, radiating, compressing, severity, 9 by 10 pain or 10 by 10 pain. Apart from that, aortic things can be possible, esophageal things can be possible, respiratory things can be possible. So which you can tell in this part, including heart stress. Don't forget that one. This sometimes case comes. And also, I told in the beginning, psychiatric, it should not be missed actually as well. So it was there, like, so doctor asked about that one, that are you in a lot of stress and the thing, stress on the thing. So if you are telling that in a lot of stress on the thing, then in the DD, you should also tell that one. Since you were asking that thing in the history part that, are you in a lot of stress? I said, yes, a lot of stress was there. So it can be because of a stress, cardiac problem can aggravate, it's common, but it can be psychiatric problem too. So in DD, I mean, you should, so your history and your final statement should match. Please take a note. Your initial history, physical examination, and your final statement should match. This is one of the part many doctors make mistake. They don't remember things. So memorizing, memory power, these are very important actually. Right? You guys actually know things, but in the exam hall sometimes because of. Now, Dr. Faiza, can you come to online? So here, the moment of truth. Can you turn on video? But that's okay. Anyways, so a feedback is actually given in that way for maybe Dr. Faiza. Okay, disappeared. Anyways, so feedback of chest pain. I mean, okay, so history. Probably I would like to give her probably 3 here because family history has been missed. So 3. Examination and sequence maintaining, I would give probably in that part she was doing well, but she missed thyroid, she missed edema, dehydration, that part. Others it was okay, still I can give her 4 on that part actually. And lastly, DD and diagnosis and further thing, probably I would give 3. At the end, her flow was little hampered. And again, time management, if I also add that one, there will be cutting off marks for sure. in those stages. So she might not be able to finish the DD well. That case more of time management. So I would say it's like 3, 4, and 3. Global score, I would say also it's like 3. She did well, but I think it's not highest up to the mark. But the same case, I'm sure when she will do well, she's very good role player normally. But next time when she will do, I'm sure in any cardiac class next time, it will be a pass case actually. So sometimes we just need to be focused. I'm sure she knows very well about that thyroid thing is necessary, but it's just moment of concentration and the things that matters. Family history, I'm sure all of you know, but sometimes just, I mean, due to some moment we forget the 1-2 points. I mean, so these are sometimes silly things we do actually. We all have to be careful on that one. Just follow the format properly, ask the general important things. So unfortunately, I can't make it pass. So Dr. Faiz, I'm so sorry about that, but I'm definitely sure. But you know, you had past case before. So I believe like, you know, you will study more medicine shortly, right?
Yes, yes, of course.
Okay,
You
sure.
know
I
what I
mean,
realized is knowing and practicing is totally different because
yes,
when you go to say, you miss a lot of things. You need to really, really
exactly.
practice.
Yes, I mean, the points you missed, actually, you know it. I mean, you see that the points you missed, you know it actually very well. You know, if there was something, okay, you don't know that and you missed because of that, it was not that case. But family history, you know, the appearance thing, you know, and also, you know, few things in the DD, like adding psychological and few things, and investigation D dimer, you also know. So that's some of the points. So just bring those notes and the things into your practice, do a little bit more. And correcting others, I also like to add one thing: correcting others will make you memorizing. So if your 3 friends are discussing, one friend is making mistake, you guys are laughing due to some reason, so in that case, you know, you will remember that one because of something, we crack a joke or we miss something. So that particular thing's actually remembered in the brain for longer time actually. But if you just study alone, everything will be the same. So that will be the drawback of that one. But you did good job. Just focus on the time management, a little concentration, maybe next time, and maybe a little more practice because there's some initial days of cardio on the medicine. So it'll be fine with time, I'm sure. All right, good job. So our next role player, please be ready.
Doctor, I had a
Yeah, sure,
question.
sure. Yeah.
Uh, it had a focus history. So in focus history, what history can we avoid? Uh, that what history are
Hmm.
not necessary in focused
All right.
history?
Focus history means like, see, Dr. Pfizer's case was cardiology. Yeah. So example, she mostly will ask about the cardiology cases. I mean, cardiology, thrill, murmur, added sound, heartbeat, apex beat. So that's the main one here. Actually, should definitely need to ask. And other focus means, you know, any abnormalities in respiratory, no other thing. And how about the neuro and the other examination, you know, negative. You know, just go very superficial. Actually, I mean, there is provision of skipping things. There is provision of skipping things in focused history. Focus means, you know, focus more on the cardio, focus more on the cardiac history. That's the main thing. All right.
Okay, okay. And one more thing, how many question can I ask? I mean, can I ask like this? Do you have nausea, vomiting, cough, breathing difficulty, uh, like
Yeah,
this, or
that's on
just one
them.
by one?
Yeah,
Just
that's on them, and their primary language is English. So I mean, compared to us, they can remember a lot of instructions well. If the same thing I would have talked to you in Bengali, I mean, I'm sure, you know, if I ask a lot of things, you know, you will not have problem, right? Normally. But so
Okay.
for them, if you give multiple instruction, I don't think so it will be a problem. You have nausea, vomiting, and blah blah. So
Yeah.
they say no,
Okay.
no, 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 no. I mean, it's very normal for them actually. That's the thing.
Okay.
Actually, even second same goes with examiner, and that's also test for them, right? That, you know, so do you have this, you know, say in general appearance, pallor, clubbing, you know, and cyanosis, colonychia, just to give them a chance to breathe. No, negative. Any, you know, edema, dehydration, or any abnormalities in thyroid? No. So that's the way actually. So multiple instruction can be given. They are also ready for that because um, the candidates also need to save time. They also know that. So they're also ready like that actually. They will manage it. They will manage it actually. Okay. It's a nice question. Anyone have question like that? Anyone have questions, something like that? Interesting question. All right. Okay, one more thing I want to tell, some new cases probably that has been tested. As I said, in the last class, we'll talk more. I'll give you some more information, or we'll try to make some more note like that. So with chest pain in this 2021 case on is 27th of April, was chest pain, shortness of breath, and the leg pain, old man, long travel history. Chest pain, shortness of breath, leg pain, old man travel history. This one can be what diagnosis, guys? Chest pain, shortness of breath, leg pain with a long travel history. Long travel history
Pulmonary
means,
embolism.
yes. So that can be a case. And what could be the DD, guys, of this case?
DVT.
Some, okay, DVT. Anything else? Of course, I mean all the other chest pain related thing you can include here. Panic attack, well done. Someone said panic attack, well done. Anything
Pneumonia.
else?
Myocardial
Pneumonia, well done.
infarction, angina.
Yes, all those slots will come now actually. Central chest pain, all those slots will start coming, including even ZRD you can also bring in that case actually if it's necessary. And don't forget to bring the panic. Someone said panic, I liked it because panic also, they feel like they're dying, chest pain, they have also like shortness of breath, they're feeling like panic is a very nice one in that case. Pneumonia is also similar. They have chest tightness, chest pain, and breathing problem. Can I also add heart failure in this case? See, old elderly person, chest pain, shortness of breath. Can I also add the heart failure? Yes, definitely I can. And of course, any chest pain is suspected myocardial infarction, arterial fluid, otherwise, right? So we should also include that one in that sense. So now we know we'll get into the history. We'll exclude the same Socrates. We'll exclude the same Socrates. We'll be highlighting a little bit more on the travel. Then we'll finish the case with the family history, right? We'll finish this case with the family history. Now there won't be any family history, or you won't see anything in the past separately, like say individual hypercholesterolemia, hypertension, so many risk factors. You might not see that, or rather, you will find a long travel history. That's the significant. Long travel history means when the air is, I think the plane is more than 8 hours. Actually, is called mostly long flights. Actually, if you go to Bangladesh to Bangkok, it's not a long flight normally. All right. Also, the recent surgical histories, still do ask it because you are going to make a diagnosis on pulmonary embolism. You still do ask it, like in any recent surgery, any recent uh, bed rest for a long time due to any reason. So you do try to ask, make your cases more stronger. Then you come up. I mean, eventually you come to the physical examination part. You go through the ECG. Pulmonary embolism has some X-ray finding. Pulmonary has some ECG finding too, actually. So X-ray weights your opacity if X-ray is present. ECG, Q3, T3, that particular finding, and then comes the investigation part. The investigation would be as similar as ruling out CBC, than this chest X-ray, ECG. These are as like mandatory. Of course, X-ray will help you ruling out the wedge shape, opacity, and the things. But you still need to do more things, like which is required for pulmonary embolism. Like you need to go for CTPA, that's required eventually, and D-dimers. These are the things. So these additional things you definitely need to add in your bucket. Okay, so ruling out the same formula kind of I'm using for the investigation, same formulas I'm using for the DD. So once you know about chest pain, it's just additional points, shortness of breath or leg pain. Try ruling out the other DDs in that way. Finally, come up with management, some short-term management, some long-term management. So what is the short-term management of pulmonary immediate management? Of course, we'll take the patient to emergency cubicle and all these things because patient might not be vitally stable. Okay. So in that case, what are the management available? Anyone can add here some points. Anyone unmute and tell what is the management of pulmonary embolism? Anyone?
Anticoagulants like slow molecular weight heparin.
Can we start with immediate? I mean, I want to know. I mean, if I will be the patient, oh God, I'm having, pulmonary embolism pain. So what will be some of the? I mean, that's a very specific one. I can understand.
Thrombolysis.
No, go back a little bit earlier. I mean, you need to, do you need to tell me that, hospitalization is required for you? Isn't it important?
Yes, yes.
Another day, I think I told all of you, if you don't mention about your patient status, that, for this condition, I need hospitalization or not, either patient will ask you or they won't ask you, your marks will be cut in that case. So it's very important that, you mention about hospitalization. Definitely. So hospitalization, then propped up, is it required? So we'll be putting you in prop, then give you oxygen and blah blah this thing. Um, then for a very specific treatment, we like to give you the low molecular weight heparin, which is a very specific treatment for pulmonary embolism. Before that, we have already said your diagnosis is pulmonary embolism, and it can be some of the other causes which I also need to rule out by doing some other test, right? And then stable and unstable, I mean, it can be extreme cases. What can be done apart from the medical? Yes, we know that this heparin is the treatment. Anything else that can be done? I mean, if it's unstable, patient is dying, you give heparin, it didn't work. Patient's condition is deteriorating. Is there any surgical approach that I want to know? Yeah, surgery. You have to open up, remove the clot mechanically, remove the clot mechanically. Right? So we keep it in mind actually. So in your case, I think by giving anticoagulation drug, you'll be fine. But just to tell you, John, some rare cases, if it's become more unstable, it might also require surgery. So give it in patient's mind, give it in also examiner's mind too, that you are aware of that one. You're not mentioning surgery means examiner will think you might not aware of the thing. So I don't want to mean you scare. I mean, there's some word to that. I don't mean you scare. You even might not require, but some cases might be surgery required, and you just tell in that way if your medical treatment doesn't work. So you have to give these things in patient's mind. But we'll try our best. We have a best team to work for this thing. We'll try our best to, in your case actually. And don't worry, I'll be there also to guide you. And also some expert cardiologist will help you. Yeah. So just tell about those things, mention about hospitalization and all these relevant things. All right. So this is one of the new. I mean, do you think it's that tough? I mean, if it comes in a little different way, is it that tough? If it comes in a little different, same chest pain case, that came as a shortness of breath and the leg pain and a long travel history. Very simple. It's a pulmonary embolism case. Approach is same. That starting with the Socrates, then past history, family history, SADMA, all these things we ask. Then we get into the physical examination. Ask about key things, ruling out the other points, ruling out murmur, ruling out rub, ruling out other respiratory findings, right? Physical examination is not for just get into the finding of this. Physical examination is basically given to ruling out the others. All right, then you come to investigation. Investigation is similar as this, some of the heart attack things, but you point out more the D-dimer and the CTP and the X-ray more, because it's a pulmonary embolism cases. Other things should be also done, as like earlier we saw in cardiac. Just rule out, make sure you don't make any mistake. Right? Then you tell the patient diagnosis and the DDs. Yeah, so that's all actually. It's not that tough. But there's a second case given, a 62-year-old having a chest pain and take history, and it is leading to pericarditis. So what is provided? Oh, sorry. So what is provided? The PFE. 62-year chest pain. Now you have to take more history. You have to take more history. This type of case where your information is too less, that means you have to ask a lot of things by history. Now this is another way to learn. So just very simple, just telling chest pain, simple history, and they will also mention about prompting. I will clear the prompting thing in the next class. How it was. One day, if I tell everything, it will be difficult for you guys. Prompting, I'll clear it, but when the instruction will come, they will tell it from the beginning. So take the history. So these are the cases where you will take proper history. If it's pericarditis, definitely you will focus Socrates, and in between you look forward asking, it's like lying flat, there's more pain, Deep inspiration, is it causing more pain? Is there any respiratory tract infection few days back? You'll find yes probably for this particular points if it's a pericarditis case. Okay. So, and then finally finish with, do the investigation as like general cardiac earlier the case we do, because you also need to rule out the heart attack. We also need to rule out pulmonary embolism. You need to rule out pneumothorax, pneumonia, these sort of things. Right? So in physical exhibition, it would be ruled out. If there is any way it's pneumonia, you will get to know that one. Okay, so diagnosis and finally the DD. So if your diagnosis would be pericarditis, the other DDs would be heart attack, um, angina, ZERD, and aortic causes, respiratory causes, pneumonia, pneumothorax, and don't forget about some cases can be psychiatric. Yeah. Right. So that's how we'll done these things. We have also seen cases, chest pain, shortness of breath, and in physical examination, we get to know one-sided breath sound is reduced. One-sided breath sound is reduced. So then we turn the case to pneumothorax in that case, right? And follow the protocol of pneumothorax investigation, management, inserting needle, cleaning, more focus on that one in that case. It's not that tough, be calm, you'll be fine. But in the same flow, many people don't keep it in the main exam. They got puzzled to solve it. Okay, and that they probably don't like. Okay, one of the practice case for you, just I brought that one just to give you guys idea. Just a quick competition for you guys. Read this case, tell me a diagnosis.
Angina.
Okay, let me give people 1 minute of time. I want everyone to participate and write something. You can unmute and
Stable angina.
Okay, somebody was using stable angina. It's a retrosternal, right? When you said retrosternal, so that means it's central retrosternal last for 2 minutes.
Tapu.
All right, someone's microphone. Yes. We have a small baby as well. I think that's okay. No worries. Yeah, often it happens. Yeah, they will pass MC more quickly, those kids, if someday go for MC. But anyways, okay, so last for 2 minutes and occur more with, if you do exercise, it is effort intolerance, right? This has a term called effort intolerance. Okay, relieved by rest, not related to food intake. So that means you kick out the ZERT. So now here's some point. Our time is up. Let's remove it. So these are some of the points to be keep it in mind, including angina, heart attack, esophageal thing, heart pace, pneumonia, and probably ZRD I should add here as well. I think I should add ZRD as well. But ZRD is very easily ruled out. Very clearly it was ruled out. Yeah. So some of the relevant actually we like to keep here. Angina, spasm, esophagitis, central chest pain, heart pace can be pneumonia. Yeah. Okay. So that one was the diagnosis was for this case was angina, stable angina. Right. So far I guess we have some idea for this case. Now we'll go for another one. Is it Dr. Kaihan will come for next one?
Yes, sir.
All right. Okay, before you jump into the thing, I'll hold here for a second. Any of our dear doctor, can you tell Dr. Marzia or Dr. Charuni, not sure like pronounce right or not. How about this case? You can unmute and tell. You have again 1 minute time. Dr. Marzia and Dr. Charuni, you can read this case. You have 1 minute time to answer. Okay, Dr. Charuni answered in inbox. Maybe she's not in position to open up mic. So she said pericarditis. Okay, She leans forward and options with improves when leans forward. So lying flat, I was telling that lying flat is more for pericarditis actually. So options with deep inspiration and lying flat. Improves with leaning forward. Any heart condition, if you go a little propped up, any heart condition, you little go propped up, lean forward or propped up. These are some of the position might give you some relief actually. So just figure it out which ones. Okay, so everyone agreed. So now moment of truth. I hope everyone is agreed. Mhm. So we came up with pericarditis, but some of the other DDRT in my costochondritis. Guys, ribs related on chest pain, it can be costochondritis, CERD, esophageal cases. Some investigation is given in this side, as you guys can see. You can add more if you want, depends on the situation. So we diagnose that one as a pericarditis. Okay, one more. In Chinese, it's called Hayoika, right? I know 2-3 languages. Chinese, I know here. Hindi, Urdu, I can speak fluently. Anyway, so Dr. Samira, what do you think? Dr. Samira and Dr. Saman and Dr. Salman. You guys try to answer. Other, please keep quiet for a second. You guys try to read this case and just come up with an answer. Really happy.
Could that be pulmonary thromboembolism?
Okay, I'll take the point. Point to be noted. Let's see others answers. Let's see others answers.
Pulmonary embolism due to prolonged
Shortness of breath we can see at rest. Pruritic chest pain. Pruritic chest pain. Tachycardia, hypertension, so instability. Recently recovers from, so history of a recent surgery. So lots of points out there. So that means that some tasks can be like focus, STP, FE, diagnosis. Nowadays in the exam, it's very clearly given. If not management required, they will tell you. If not management required, they will tell you in that case. I'm sorry. I'm sorry. Going back to last case. This was the case. This was the case. And it's, if we consider the DD, in that case, say pulmonary embolism, pneumonia, costochondritis, MI, because any chest pain until proven otherwise, it's MI, chronic heart failure, aortic dissection, and here's your line of investigation. Because I'm thinking pulmonary embolism, so the chest X-ray, D-dimer, ECG, these are jumped into the beginning. See, earlier in the heart cases, the D-dimer was here, somewhere in the 6-7. But the D-dimer now jumped in early, along with the ECG, X-ray, and the D-dimer has more importance now. It's because, so that's how you have to speak, or that's how you have to think in the main exam, right? So X-ray, ECG, ABG, because of breathing problem, there can be acidosis. That's a possibility. CBC is important because ruling out infection, some other points, electrolyte because of this hyperkalemia. Glucose is a very common thing. CTPA, yeah, is very important. Final confirmatory is this. Yeah. And Doppler ultrasound of the leg, because we like to rule out what? Doppler of the ultrasound to rule out
DVT.
DVT, yes. So all those points are given. You just need to be calm down in the main exam. See, line of investigation is to some extent similar. Few sometimes we brought early, sometimes we just bring it in the later. Depends on the what is the diagnosis you are making. So in our case, our diagnosis is actually, for this case, is pulmonary embolism. See, same with the chest pain. Often you might get few things. Along with the chest pain, you might get pulmonary embolism, you might get pneumothorax, you might get heart failure. So all comes from the similar chest pain thing. One of the cases are so important. So as I said, this same chest pain and palpitation and syncope, one case is confirmed in the main exam actually. If you just know the approach, I'm sure you can just nail the exam very easily in that case. But the exam hall, people were scared, so many things to study in at a time. So as you guys can see, pulmonary embolism, chest pain, breathlessness problem. Okay, so these are the problems out there actually. So, and yes, when you do the X-ray, there'll be some finding. X-ray is having which shape opacity. CT scan also has findings, of course. So we discussed about the DD. Early page was mentioned about our DDs. Algorithms means our DTs and our line of investigations. All right, that was mentioned in nice way. And last but not the least, earlier I also asked about management. You guys told me the management. So there is immediate, then some medical management, then some surgical management. Immediate management, always remember, clear your patient's position that, whether hospitalization required or not required, whatever the conditions are. We treat this condition outpatient. This gives a very clear instruction both to the patient and to the examiner actually. It gives a very clear instruction. So we can treat this condition outpatient. We have to hospitalize you. So please remember and bring it in your practice next time. Some cases ECG explanation can be there. We'll see about that one in the next class. But some of the MI, we all know that some reciprocal involvement is out there. Reciprocal involvement is ST elevation, some specific leads that is involved with ST elevation. Okay, some cases ST inversion, and those are also involved. So just need to keep it in mind actually. Okay, some cases ECG can be there. They might also ask you to explain the ECG. Some cases there will be a provision to explain ECG. We'll talk about that one next class. For now, you remember the points, you remember what are the ECGs. We'll give you explanation in the next class on that one. And yeah, so this is one of the ECG. All right. ECG, radiology, for example, liver metastasis, CT scan. So these things are available in this screen. So just click and it will come up actually. There's an option, the examiner shares the screen, guys. You all should know, examiner actually shares a lot of things, including the screen. There's a one doctor appeared in the exam 2 or 3 days back. So had a little chat. He was tired actually, so I couldn't talk much. All he said one time, his screen was not coming properly, So then he was telling, can I see the screen again? Can I see my question again? Because sometimes, Zoom has the option. See, if I just pressing it, it's going. If I'm pressing it, it's coming. So they also have controls like that. This is also new for a lot of examiner. Not as everyone is as very expert, and human error is common. A aeroplane is flying, aeroplane also falls down. It's the safest vehicle of the world, but aeroplane do crashes, and this is the MC exam. So you don't expect everything to be perfect from their side as well. Okay, so sometimes freezing screen and the things you have to, as I said, the IT thing we'll talk about tomorrow. So I'm just saying that explanation, what happened to the doctor. So doctor said that, okay, like he complained that, my screen was frozen and the thing. So later, all the exam when finished, there were another 3, what should I say, victim or culprit, whatever is the word, along with him was also in a room, so we call it breakdown room, so you can see others. So because exams are done, then why he is here? He has one station left. So similar like him, among the other 18, there's other 2, 3 he saw. That means the same incidents in the same day has happened with some of the others. Yeah. So well, he was making fun that, there's like other puppies are also with him. So taking the remaining. So they have arranged separately. If you complain my screen frozen for this station, they will give you the separate station. Once everyone exam is finished, then the whole exam will be completed. Otherwise, no one is allowed to leave the exam and the things. All right. I hope you get some clear idea. I hope so you're getting some vibe, right? I'll update you more once, there's a one more anterior. Let's see, because these leads are involved. Let's see. This is anterior MI. Yes. Okay, talking about acute management of MI, just little bit MI management just for you guys, because we asked you so far the question, because questions mostly come about history taking, physical examination and diagnosis DD, or they give you the very big scenario. So some doctor also said, you must be seeing some feedback. Sometimes very big scenario given, what does it mean? You don't have to take the history. So you might only need diagnosis and DD and the management. So if it comes in that way, initially clear the patient, reassure, pamper your patient, don't worry, we'll do this, that, okay, giving you oxygen and the things and painkiller. So start with monotherapy or me mona, whatever you say. So some cases the patient have nausea, vomiting feature, especially with MI case. So that's why mona or me mona, whatever you remember. Then it comes very importantly that ECG and the cardiac marker to send. um, you mentioned if it's in the hospital, then arrange a cardiologist, or if it's in the local area, do refer the patient quickly after giving monotherapy. So please be sure where you are, rural level, or you are in the tertiary hospital. You need to be sure you are in a GP center. In GP center, you can't treat the MI. You maximum can give the monotherapy and refer the patient. So if it's in the hospital, I'll call the registrar, I'll call the cardiologist, and what they're going to do, angioplasty. Tell one or two sentences about angioplasty. I repeat, this is my suggestion for MC clinical all cases. You need to know at least one or two sentences about the procedure, about the in very simple term. Do not use the medical jargon while an angioplasty will do. I mean, this that way. I mean, just make it simple. Try drawing. Yeah, you can also have a pen paper, right? You have a pen paper like that, so which you can draw, and you can show, see, this is how blood vessel, narrowing of the vessel, and I will put a stent. You don't have to be a good, I mean, drawing expert to do that. It's just show off, guys. Yeah. And last but not the least, if it's a management case, they're focusing more on management, they're focusing more on counseling. So definitely long-term drug adjustment, long-time exercise, long-term sleep. You make the cases more longer, telling more longer way, telling pharmacological and normal non-pharmacological. Non-pharmacologism, I like to add a word, SNAP. Snapchat, I'm sure many of you are using. I don't use it, by the way. Anyone using Snapchat? I mean, I'm not sure is it good or not actually. Yeah, maybe I'm not sure Dr. Intisar is there or not. He's good with the different devices. Anyways, so Snap. This is Snap means smoking, nutrition, alcohol, physical exercise. That's the thing. Yeah. All right. Yeah, he understood what do I mean to say actually. Yeah, I don't want to bring those. Okay, so that monotherapy, onam therapy, please remember, ST elevated MI cases, monotherapy, non-ST elevated cases, onam therapy, immediate treatment, medical treatment, surgical treatment, long-term treatment. Okay, keep it up to like that. Keep it up to like that. All right. So this is all about that management. I mean, you try to be smart, don't miss the points. Don't forget to tell two lines for angioplasty, how it's done in layman's term. You can draw even, we'll put the stent through your arm and many things like that. Yeah, so we're discussing acute management of MI and a little bit more information. If collapse, then call for help, is the ECG, adrenaline, because some cases they might say patient is not stable. Okay, so then in that case, this you can remember additional actually. But telling the cubicle is more than enough. These are so extra things. So the last two slides, guys, you don't have to worry because we have to module slides and bring things in the slides. So that's why it's there, but it's not like always you have to tell that actually. Right? Okay, you can see it later. Pulseless cases, CPR, shockable cases, DC shock. Depends on some management. You should know about it. Yes. So these are so slides. This might not be required for in the exam. There's a one thing might came, cardiovascular, some cases risk assessment. In my YouTube, there's already one cardiovascular risk assessment given. If you see, go to my YouTube channel, Shahriar Ahmed. But since it's cardiology class, I'll definitely bring it in some of the coming classes show you one more time how to do a cardiovascular risk assessment. I'm sure you have also done that one in the AMC MCQ. Actually, many of you have seen that one of mine in the YouTube channel. I hope so. You can just type cardiac risk assessment. Then you can just type my name, Shahriar Ahmed. You will find it immediately. Actually, yes. If you only type cardiac risk, then there will be many other things will be coming. All right. So how, when is smoking, age, systolic blood pressure, yeah, how all this thing affects the cardiac risk assessment, we'll see in next class definitely. Moving forward, key point, okay, drug, cath lab, refer, angioplasty, talk about procedure, answer some of the patient's query, right? So these points will be marked, these points. So angioplasty, if it's a management case, counseling case, angioplasty, talking about angioplasty in layman's term, a very nice website, easy website, WebMD. I repeat, WebMD. WebMD means like a general patient, they look into WebMD sometime. It's for the patients it's been made. So that means the layman's word are given there actually. Okay, so you can check in the same way, heart attack, WebMD, heart attack. Yeah, so in that way, simpler way it's been mentioned actually. Do not use the medical jargon for these cases. All right. So who is getting ready for next one? Dr. Kaihan, please be ready, I guess.
Yes, sir.
Okay. All right. Is your video available?
Yes.
Okay. Show your pretty face. Okay. Oh, nice background. I hope so. You're not in beachside right now. I can see a car. And maybe destination Australia. Beach, car, rest thing I'm not telling. Just it's my talk. Yeah. So, anyways. Okay. So, anyways, next thing is coming. You know the instruction. There will be a screen will popped up. You get 2 minutes for that. I'm also getting ready with my timer of my own. In the main exam, if it's a Zoom-based exam, because you are in India, I know you personally, you will get to get the chance by online exam, right? So for you, I mean, maybe the typical physical examination won't be there. Someday we'll do the do a practice in that way. Okay, no worries. Actually, for now, do the practice is in the general way, but before exam, make sure you practice in that way. Actually, how it's coming. All right. So here you go. I mean, let me see if any question from anyone. All right. Next. Here you go. You have 2 minutes of time to read and process things in your brain.
Is it the same case?
I guess kind of similar, I guess. Let me check. Yeah, it's been, I guess, similar, but I mean, um, Yeah, good observation actually. No worries. I mean, you can play that one. Practice. It might not be the same diagnosis. You don't know yet. I mean, unless you get into the history, I mean, you don't know yet. You know what history might be coming out actually. Yes. It's a, okay. One correction, Dr. Kaihan. So this the chest pain that lasts for uh, let's say 6 minutes. Okay, it's counting like that, not like 60 minutes. All right. Okay, so are you ready, Dr. Kaihan, for
Yes,
your
sir.
case? So you can start your case. Yeah, here you go.
Examiner, this is my ID.
All right, looks good. You understand your case? All right. Your patient is waiting. The patient's name is John. You can start your session.
Hello, John. This is Kaihan, one of the GP here today. Ahmed.
You can call me John.
So, John, from the history, I have got to know that you have pain in your chest for last 6 months. Before that,
Yeah,
I
I
would like to
mean,
ask some question to the examiner, and I will. So, dear examiner, what is the pulse, BP, temperature, and saturation of the patient?
okay, the patient's pulse is currently 95. His blood pressure is currently 135 by 85, and his temperature is 98.4, and respiratory rate is currently 22 breaths per minute, and saturation is currently 96.
So, dear John, I would like to ask some question according to your pain. So, can you explain how much severity is the pain? Is
Oh,
it
no, sir,
from 1
doctor.
to 10?
Actually, yeah, I would say it's a 9, doctor. I'm feeling very bad because
So,
of
do you
my
have any
pain.
allergy?
Allergy to
Do you have
what?
any allergy? Allergy to any medication?
No, actually, I don't have. Not in my concern.
So, would you like me to give you painkiller?
Yeah, that'll be all right if you get me. Actually,
Yeah.
it's. I mean, I'm feeling like I'll die. Actually.
Okay, so I'd like to admit you to the emergency cubicle and we'll put you on cardiac monitor and also high flow oxygen, 8 liter per minute, and also do also ask the sister to do an ECG. Yes, and we'll keep morphine and metoclopramide. Is the patient
All
fine?
right. I'm feeling better now. Actually. Okay. Thank you.
Okay, so since when? What are you doing? The pain happened. Can you explain me that?
Actually, doctor, as I usually I like to take morning exercise and everything. I think for last 1 2 weeks, I'm not feeling of my own. Actually, it feels like not getting the enough air. When I'm like jogging or walking. So especially when climbing the stairs, then it hurts more. Even. And gradually, I think lately, just like few hours back, suddenly there was sudden pain, and I also felt a little pain actually 3 4 days back. One more time, little bit. I thought it will just go away. I take some drug for thought it is a gas problem, so it went away actually. Then And yesterday it's like a sudden earthquake. Suddenly it came. It's very strong. It's just few hours back. It was terrible. So just thought of coming to you as in the hospital for further management.
Yeah, can you look at the pain site exactly?
Yeah, that's here, like exactly the center. Felt like a heart problem.
Can you explain the which type of pain? Is it constricting type of pain? Like,
Yeah, it is restricting my heart, I guess. Yeah. Yeah, whenever it comes like for 5-7 minutes, then it goes away.
and have you taken any medication for this?
I took medication. I took the general painkiller. One of the friend actually suggested some kind of little, it's called something GTN, I guess. I'm not pretty sure in your tongue. So he said he has this type of thing. So I took it under my tongue. Then I was feeling relief actually. But otherwise, the painkiller didn't work much, to be honest.
Is there anything that aggravate or relieve your symptom as it
Yeah,
happened before?
when I take walk or climb stairs, though, that time.
Okay,
Or
is the
heavy
pain
meal
radiating?
probably.
Is the pain radiating to any in your chin or your arm and shoulder?
No, not really. Actually. Mhm.
And
It
do you
felt
have
in the
any fever?
central chest pain. Yeah, no
Do you
fever.
have a fever? Any cough or cold?
No, I'm not in my concern. Any cough, cold, no.
Do you have any recent travel or any
No. Since COVID is outside, so we are not getting chance to go outside much. Only morning jogging and work from home. Yeah.
do you have any past history of this type of symptom or any other chronic diseases like diabetes, hypertension, as you were taking since when you were taking this medication?
I was diagnosed with hypertension when I was 40, so I've been taking the drugs since then. I also have cholesterol problem. But heart problem, probably my grandfather had these issues. I guess I remember.
Okay. And do you take the regular medication daily? And since when you have visited your GP last time?
Sorry.
Uh, since when you have last visited your GP last time? And are you
I think
taking the medication
it's been 2 months. It's been 2 months.
Do you have any family history of any cardiac diseases or any diabetes or any cardiac?
Yeah, yeah. Family history of cardiac disease. As I said, my grandfather was diagnosed. But what cardiac problem? I don't know. I'm almost not sure.
Okay. Any history of sudden death, cardiac due to cardiac cause?
Not in my concern. No, I would say. Anything else you want to ask in history?
Yeah. And do you smoke or drink alcohol or take any recreational drug?
Yeah, I was smoking alcohol occasionally and no recreational drug. Never do that. Um, not allergic, of course.
And how is your mood and bowel, bladder, and sleep appetite?
Sleep sometimes because of work load. Sometimes it might be hampered. I feel like sleep has been hampering, sleepless. Otherwise, I'm fine.
And do you have any respiratory distress?
Uh, right now, I mean, maybe when I came, I had little with the chest pain. I'm having little issues. Yeah, breathing problems.
So I'd like to ask some question to my examiner, and I'll be back.
Yes.
So, dear examiner, what is the BMI of the patient?
The BMI of your patient is 30.
Okay. And what is the patient vitally same as before?
Yeah, it's same as before.
Is there any radial delay or any postural drop of BP?
There's no postural rush noticed.
And is there any pallor, sinuses, jaundice, swabbing, edema present or dehydration?
Negative for those.
Is there any neck gland, neck vein present or any thyroid?
Neck lymph node, no enlargement, edema and dehydration are absent.
Okay. Is there any rash in any part of the body or any discoloration of skin?
No rash noticed, no such discoloration. You can move to next task.
bilateral breath sound equal and normal, vesicular.
Yeah, breath sound is bilaterally equal, and it's a vesicular breath sound.
This one is audible and any murmur present.
Sorry, I didn't hear it.
This one is too audible and any murmur present.
No murmur, no added sounds being noticed actually. And S1, S2 present.
Okay. And on neurological examination, all the cranial nerve and all the sensation and powerful reflexes.
Yeah, neurological examination normal, you can move to Nestus.
Okay. And abdominal examination, normal.
Nothing abnormality detected.
Okay.
The bowel sound is present, you can move to Nestus.
Okay. So from the history.
Okay, just to clear one thing, Dr. Kaihan here. If you're going for online exam, this physical examination part will not be with the examiner. It will come in your side of your screen directly. Okay, and it will be given field instruction in the exam, like no need to do physical examination, and that is called prompting. So you will get that examination at a certain point. Okay. So that's the only difference. Just for practicing purpose, we're practicing in that way. Like, you can move forward. Yeah.
Is there any office test available?
Sorry, I didn't hear the last.
Is there any office test available?
Office test is available. Like blood sugar is normal. Then what else you want to know?
ECG.
There's a ECG available. ECG is showing ST depression actually.
So, dear John, from the history and the office test available on the examination, the most likely diagnosis you have is called stable angina. Have you heard about it?
I heard about it, but I'm not sure. Can you tell me?
Yeah, in this condition, the blood supply to the heart get hampered. That's why the pain and the heart can't work properly. That's why the ischemic causes the pain to the heart. So for your case, this thing happening to you, and it can be caused by blockage to your vessel to the heart, like fat.
Okay.
Get blocked
okay,
to your block into your vessel, so it get hampered. And sometimes other causes also happen, like anemia can cause this type of oxygen supply delay or oxygen supply hamper can happen by this cause. So we will surely look into it. So before that, and before that we are going to admit you now, and we'll also review, inform cardiologist, and we will also review you, and also we'll send some investigations like CBC, CRP, sodium potassiuria, creatinine, and ECG also, and also an echo. Echo will be done. Yes, and do you have any other question? Also,
no,
a chest extra will be done. Yeah.
Okay.
Do you have any other question?
So how is it possible that this situation will be? I'll be fine from this.
Yeah, obviously, it is a very common condition, and it will be fine after all the investigation.
I'm scared right now, actually, because
no.
I thought maybe gas problem or something. It looks like you're saying it's the heart issues actually.
Yeah, there can be other causes also, like it can be pneumonia also, it can be a pulmonary embolism also, but and also gas problem, as you were saying, and also gallbladder stone can be, and also peptic ulcer disease can happen also. So we will surely look into this matter also, and after the investigation come, we can say it.
And how will you treat me for this?
As I have given to you morphine and also metoclopramide, and also give you aspirin and oxygen. You are in oxygen, and also give you nitrates and.
Right. So, doctor, thank you, and would you like to finish?
And also angiography will be done for you, and it will be said.
All right. Sure. Do you want to finish your case? All right. Yeah. So thank you, Dr. Kaihan. You actually took 12 minutes, so that's why I have to stop you at the end. But case is long. As I said, normally the 5-component cases doesn't come in that way. First of all, either they will ask you history, physical examination, or investigation, either an up to diagnosis, or either they will ask you about investigation, diagnosis, DD, and the management. And, somewhere it comes in. And as per, as I said, PEFE concern, we're practicing in that way because we have both type of students actually. That's why we're practicing the PEFE still actually. But as I said, I mean, just before online exam, if it is there, the typical PEFE, will be nowadays because the examiner will not talk to you. That's the different part here actually. So we'll do 1-2 cases like that as well. Don't worry. But because it's now divided the MC clinic. One is the Melbourne NTC and one is that online based. Did you get any date yet? Finally, did you manage? Okay, you can tell me later. No worries. Okay. So, so how many of you got date actually? Before I get into sum up this case, how many of you have a date, guys, for the exam? You can let me know in the chat box. Okay, one doctor asked, an online examiner is designed there to talk with us. So who will tell about the stability? That vital will be given in the site. Yeah, the vital information will be given in your question. Okay, that part that Dr. Kaihan is asking will be given as a vitals. So that's why I said there's a lot of thumbnail. You see, there's a lot of thumbnail in YouTube. So you'll see in the feedback, a lot of people are saying about big screen because lots of thumbnail are there in the screen nowadays. So vital would be also one of them because examiners will not confirm those things for me. Right? So that's one of the point actually. So this little readjustment will be required while practicing actually. That's the thing. Yes. So we'll do want to practice. Maybe the last class of cardio we can practice in the same way. Those of you
Can I ask one question?
Yeah, sure, doctor.
If vital is there, so should I need to ask, is my patient is vitally stable or not? If it is there. In
See,
real
it's the
exam,
same question. I mean, let me just make an adjustment. What if I just make a line here that vital are these, and they will give you an instruction here. You don't have to ask the vital. Rather, they are giving the instruction in that way. This is your vital. You don't have to ask about the vital. This is your physical examination finding.
so in the initial part, should we tell that as my patient's vital is stable, should we go for further history?
Yeah, like see, your information will be given here. Your patient's vitals are. So when you see the vitals of the patient, you'll get to decide, right? Like if pulse, blood pressure, temperature, respiratory rate, saturations is already given in the screen.
Yeah.
So you can easily read it and you can take the decision easily, right? Stable or not stable.
Yep.
In that case, actually. So we'll see that one. And so nowadays, in the same questions, there's another small column, vital is given, or also sometimes there is a small thumbnail. The physical examination comes as a thumbnail in the side. Okay, so that one we also need to be careful that about a little larger screen actually. Yeah. Okay. So yeah. So instruction. One more thing I can tell you, instructions will be very clear cut. Those 2-3 doctors I get to talk, they said the instruction was so clear cut. And as I said in the second class, we'll guide you guys more about prompting because this one class is everything telling is a little tough. So we'll guide you guys more about prompting. So prompting can be in 3 minutes, prompting can be in 4 minutes. Okay, prompting can be in the beginning. So we'll talk about that one, the prompting. So prompting will clear you more actually that what is going to happen actually, right? So this is the point actually. So they will clear. Yeah, they will clear the instruction very well because they have been trying for whole 1 year. Of course, they they have been doing trial and error to make it perfect actually. So in terms of instruction, everyone is telling one thing. The instruction was so clear cut in the main exam. There was no problem at all. Okay? So you will not have that issue, whom to ask, whom not to ask. There will be a lot of small thumbnails in the sides like vital, physical examination, or if you have to do this or don't do this, that is also written now in the screen. Okay, so that will clear your doubts actually.
Thank you, doctor.
Thank you. All right, so coming back to Dr. Kaihan. So Dr. Kaihan is doing this case, right? I was doing this case actually. And also there's also case like that, like criticizing that one. I said one thing, if you have noticed some of the difference, that I said one thing, here just count that chest pain as a few minutes considered. uh, MI pain would be more actually. So I need to correct that part actually. Sorry, here it should be 6 minutes actually. It remains as 60. Apart from that, you see some of the family histories out there. Good cardiac problem runs in the family. You do ask few things. You managed to make the diagnosis. It was angina, because in the ECG I also said that when there is a ST depression, right? So you also get idea. So elderly, sorry, the chest pain less than, it should be less than 60 minutes non-radiating. So it's a correction, less than 60 minutes non-radiating. With drug, no much relief. Actually, that's one of the things, except for GTN. So with drug, not much relief. Means a typical over-the-counter drug, but it is relief bit with the glycerin trinitrate. So that's another feature of this angina thing, actually, right? That's the thing. MI pain usually does not go much with the angina. That's another point actually. MI pain usually does not go much with the like GTN. Is the thing. And also pre-existing cardiac problem is there in our case. So there was no such problem for Dr. Kaihan to ruling out this was a angina case actually. So he started nicely, because there was like pain and the thing. He started nicely with resuscitation cubicle, oxygen, ECG, morphine. He talked about those things. Then things came about the Socrates. So he started various exact location, scaling of pain, the character of the pain, anything aggravating. I said, climbing stairs, it aggravates my pain, or a meal is aggravating my pain. And afterwards, um, he also had this pain, but same thing, to Dr. Faiza and Dr. Kaihan. Being empathetic in between the exam is also important. Are you feeling better now? Are you okay now? I mean, that means, I mean, you should not think you are also faking. That's one of the things. In future, I think Shah Rukh Khan should give MC exam. We are not actors. That kind of that they want. All rounder nowadays, I guess, that, has to be so perfect even people can't fake. They're faking and you can't fake. Yeah. So I think, those have good results in AMC. You might also have a good career in acting too, I guess. Yeah, in future. So anyway, so associated symptom and things which I told, cardiovascular risk, sometimes charts can be given. You also can see, look into the chart. But it comes as a SADMA, family history, past history, all these things. And as I said, I told earlier, while in the drug, did you ask about the Viagra, Dr. Kaihan? No, I guess. Or what?
No.
Yes, but you do ask about
Drugs,
other
yeah.
medication
Recreational
you're
drug.
taking on board. Because see, yeah, so that's okay. That way, okay. But see, these are some of the points you have to ask. Like Viagra drug, they won't be comfortable telling unless you ask that one, right? Sometimes actually. So this is something, because cardiac cases, so and elderly, you should better ask about that actually. Everyone, you can ask about that to make your cases more strong. General appearance, these are some points to be asked. Those came as a negative. Vitally was a bit fine, but chest pain and things were there that Dr. Kaihan had to take care with the resuscitation cubicle and all those things. Cardiovascular focused, he asked this thing. Nothing was, so most people are stable and the physical examination findings are normal, isn't it? That's the main thing. But why we're doing those, asking so many things bilaterally, breath sound is present or not, there is absent in one side. We're asking to ruling out the respiratory causes, pneumothorax, pneumonia, this sort of things. And upstairs dipstick, ECG was there. And finally, with the ECG, it came out that there was ST depression. Okay. So in main exam, they might also give you ECG and the things. It will be also in the side of the thing. Or in that case, findings would be written either of them. So this is the thing. So ECG showing ST depression. In main exam, if someone goes to Melbourne MTC for the exam, there is a ECG that has been supplied in Melbourne. Okay, so investigation as like the before, CG, CBC, urine, blood sugar, liver function, BNP, this is like additional thing. Why? To ruling out cardiac heart failure. Sometimes we can just keep it in mind actually. One if you don't take anything relevant about in the history, being it is indicating or excluding heart failure, when you ask that one in the investigation, BNP, then examiner still okay, like you are trying to exclude the heart failure actually. So they want to see where either by investigation, either by other point, you manage to exclude the other point or not. So it's similar like the others, but it has a new thing added because you are thinking as a you know angina. Did you mention this to investigation, angiogram and stress test? I guess no.
Yes. Angiogram is mentioned and
And
also
angioplasty you said, angiogram you said as well?
angiography.
No, graphy, that's a in the investigation you mentioned, right? See, angioplasty means the procedure. That's a angiography and angioplasty.
Yeah.
That's a
Is
different
there
thing.
if there
That
any
is
blockage there? Then
yeah, it's like ERCP, angiography and angioplasty. That's the procedure. But angiogram and angiography, that's separately in the investigation. I don't think so. You mentioned. You mentioned that one probably there, I guess. If I'm not mistaken, I could be wrong, by the way. So separately, guys, whatever it is, angiogram and stress test. Angiogram and stress test. I took it from handbook, so it's logical to add these 2 points. Angiogram and the stress test. So please make sure that you guys don't forget to mention about the stress test and angiogram. So along with the ECG, so now you understand why this is not the MI case. So this is the little difference. And also the chest pain is not beyond 60 minutes. Chest pain is like below 60 minutes, which is relieved by not normal drugs, but can be relieved by glycerin trienacmate. It's usually not radiating. MI pain is more radiating actually. MI pain is more radiating usually. Reference Davidson's medicine, if you can see. So our diagnosis was angina. Doctor tried to explain that one. If you guys have the pain paper, you guys try to draw something like that. I mean, just with a pen, actually. Of course, you don't have to make it color or things like that. Was drawing just a blood vessel. Explain with just drawing something like that. And you can also write cholesterol is depositing C. That's how it's happening. It gives a very clear instruction. Yeah. So drawing is also important. Okay. So in online, what you can do, if you draw something, see this is like the thing, just like showing, that's fine actually. All right. So coming to angina, as you guys can see, is a condition of pain in the chest wall, the shortage of oxygen. The heart is a large muscular organ. Yeah, I can turn it off here. Heart, large muscular organ pumping blood in the every second. If there is an issue or blockage, sometimes giving a real life example is interesting. See, you can ask the patient, do you have any idea about gardening? Have you seen people use a pipe? But sometimes, the water is not coming in the pipe in typically. It's because there is blockage. Yeah. So your heart is also kind of in this kind of situation. The amount of blood is supposed to come is not coming in that way because of this cholesterol and things like that. We believe. Right, so that's one of the points. All right, you can turn it off the camera, Dr. Kaihan. For now, yeah, the screen is. So the main cause is the narrowing of the coronary artery in large fat deposit. Actually, it's also common in a lot of other osteopaths because we try to make this not an uncommon situation. It's common. This is what I like. Also, Dr. Kaihan said that brought by emotional situation and heavy meal. And angina typically what type of central chest pain with this kind of feature, additional syndrome, shortness of breath, uh, nausea, sweating. These are common actually. Smoking runs in the family, also a tendency to run in the family. I also accept that. Okay, so keep it in mind. Management of angina. So admit, mona, cardiac, all this thing, and the drug, and of course the snap, and this particular thing is important. And last but not the least, you also can tell about, I mean, if it's a stable engine and things like this, could be more than enough for the treatment. This could be enough for the treatment. Actually, not all the angina, you required angioplasty at that time. So you have to assess. So cardiologist will assess that. So cardiologist and the things they will assess that actually. Like it depends. So unstable definitely required the angioplasty and those sort of things. Stable one, refer to cardiologist. He will consider for angioplasty, but do not tell like, we're going to do angioplasty right now. But in my case, you can then tell in that way actually. So you see, admit, monotherapy, refer to cardiologist, then giving these drugs. These are lifesavers. See, ACE inhibitor, reduce mortality, statin, reduce mortality. And lastly, long-time management plan, that is SNAP. Right? So in that way, you need to finish your management. As I said, normally 5 components given. So if I just assess Dr. Kaihan, excluding the management and the things. So in the history, Dr. Kaihan did well in the history part, but bad in the history. So I will give probably 4 in his history cases. Because he asked about the family thing, and also going second is something easy. That's okay. So in the examination part, thing were okay, but flow can be more nice. So I can give you also some kind of 4 here. DD and the diagnosis. DD and the diagnosis, probably I would give you 3 here actually. So more DDs can be like, see, I like the one Dr. Pfizer explained the DD. It was more nicely, it can be pulmonary, like it can be like some kind of air trapping in your lung, and can be this condition, like in pneumothorax, it can be like, so that way, if you tell, it's more nice to hear actually, if it's the DD type of thing actually. So that's okay. So could have been done more better, isn't it, Dr. Khan? Can you be
Yes, sir.
the video for a second?
Management, I should be better.
Yeah. So I guess just because it started with a nice flow, and then you can do the things later.
Time was running, so
time was running time. Yeah, so just to add, you also took around like 11 minutes actually. So that's one of the drawback actually. Just skipping the management. I'm not giving you the management part marks. That's okay. I mean, because you are given 5 components. Normally, it's not given 5 components. Even though management was not good actually. If management, if I count it, you will get 3 there actually. So global scoring is coming to me around like 3 here, and history probably 4. Here is 4. Here is like a 3. So global is 3. So I'm sorry, Dr. Kaihan, for now, but I'm sure next time it will come as a pass case actually. Right? So for your work thing would be work on the flow. So we went to second time, so I have to see you another time, the first time, how you perform, not missing any point actually. You heard few points already from Dr. Faiza maybe, but I believe you know these points well actually. So next time I think maybe third class you can give another try. That will be okay, I guess. Yeah. All right. So, but unfortunately, can't make you pass this time, but I hope so. Yeah, to make you pass in future. Okay, guys, one more thing. One practice required. So if we see that one, let's try to guess it, guys. Let's try to guess it all together. It's a new case. 33-year male came to ED. Okay, you need to get idea. Someone coming to ED might be something serious. Someone coming to GP might not be that serious on this. Shortness of breath, chest pain, and sad swallow. But with 2 liters of oxygen supply, things were fine. Other vitals, as you guys can see, do not indicate any sign of tension pneumothorax. So that means vital is not deteriorating. The X-ray showing air in the upper and mid zone. Explain the X-ray to the med school student, especially position of trachea, deviated or not, shadow, how it looks like. So these are the things you need to make it clear. When you're explaining an X-ray, this is costopenic, cardiopenic angle, this is that part, why this is black, this is like that. These are ribs, as you see. So you explain a little bit. So with anatomical landmark. So it's not that tough when explaining an X-ray. I'll show you guys, don't worry on that particular part. But this was one of the Okay, so what do you think? What it could be the diagnosis is? What it could be diagnosis? Any guesses? Anyone wants to add something? Not tension pneumothorax because other deviations are not, the trachea not shifted, apex pit not shifted, but yeah, we need,
Spontaneous pneumothorax.
yeah, it can be the other pneumothorax. There's like a lot of type of pneumothoraxes. Not to tell you. So someone just like got that feedback. I'll make it more clear in coming days. Talk about the instrument used to relieve the symptoms and the things a part of your assessment. Yeah. So tell the instrument to usually how you will relieve the symptom. Of course, oxygen will be involved there. Any needle and things you're using there. Actually, name the equipment very well. Say this is this. This is the needle. We'll use it to release the pressure and the things. So white bone needle we're going to use, and we'll put a water container. From that one, the air will passing into that. Means we're trying to talk about water seal drainage and things like that. And so you have to be very precise and make it sterile before you use and enter into it. So all those points, how as a medicine register you are explaining to an intern. So this is kind of similar like that, right? So this is something it's coming. There's something it's coming. So with an instrument, with a certain things, you just have to be more careful in answering that. This will be next class. I mean, I think Dr. Limon will take respiratory. I think more things will be clear on that one, especially pneumothorax, pneumonia. So I'll also give you instruction to add few points how to add these things to medical student. So pneumothorax and these things you can practice in our next respiratory class. That'll be, I guess, in the next Friday. All right. I want to do one more case with someone. If that's okay, someone can be online. Whose case is next one? This one I'll be
Me,
quick.
Sylvia.
Oh, Dr. Sylvia. So, all right. So are you ready for this case? Um, is that okay if you come to video? Is that okay, or you want to keep it? All right. All right. No worries. Yeah, it feels like more. You'll feel more confident in video because video is. See, I've been in health shows and the things. I've been tutoring, anchoring. But first time when I was facing the camera, I said, don't worry, I took classes every time, don't worry. But when it was aired, but before aired, actually they do cross check, like whether familiar or not. I said I was fine. So they took a screen 30-minute prior going to live. And I feel like, at that time I was not comfortable because, I was conscious that, 2 or 3 camera is focusing on me. So that particular thing happens actually. So when you go to the main exam, if it's online based and, because the person is there, might not be a familiar environment, it might be a little puzzled actually. But anyways, your time starts now. I'll waste time. I'll share those things later. Your 2 minutes started. I'll be just taking a second, okay, from you, just checking. All right, can you see the screen now?
Yes.
Okay.
Should I start now?
Okay, let me know when you were ready.
Yes, I'm ready.
Okay, perfect. All right, so you can start your case now.
Okay. Hello, I'm Dr. Sylvia. I am one of the doctor working here. So before proceeding further, I want to know about my patient general status. Examiner, is my patient vitally stable regarding pulse with regularity, blood pressure with postural drop, respiratory rate, temperature, and oxygen saturation?
All right, thank you. So your pulse is currently regular and it is 80 beats per minute. Your temperature is 98.4. Then your respiratory rate is 22 beats per minute, and your saturation at this point is 97. Anything else you want to know?
No, thank you. Okay. Um, okay. Hello. How may I address you?
Oh, my name is actually Karen. You can call me Karen.
Okay, Karen. So Karen, from the note I have seen that you are 50 years old and you are tram driver and you have severe chest pain. Do you have pain now?
I have a bit pain now, actually.
Okay, according
It's, I
to
think,
pain scale, how do you score it? 1 is the least painful and 10 is the most painful?
I would put it like a 7, actually. If you give me some painkiller, that would be good, actually. I'm not feeling
Okay,
very.
I'm very much sorry to hear this. Okay,
Mhm.
I will arrange my nurse to give you painkiller. Okay,
Sure.
and so I need to know. I need to ask some couple of questions to understand your condition. So in the
Sure.
meantime, if you feel any uncomfortable
Mhm.
pain, please let me know. And do you
Sure.
have any allergy to any medication?
No.
Okay, okay. Thank you for answering my question. Can you tell me more about your chest pain?
Yeah, I mean, I wanted to tell that. So, usually I didn't have this thing before. Okay, first, let me try
Okay.
to clear it. And I noticed, I guess, this situation is happening, in recent time. I got little probably flu, like 1 or 2 weeks back. And after that, I'm feeling like I'm having some chest pain, and maybe it's radiating. And also, I feel like, it's compressing my heart at the same time. And
Okay.
when I sleep, it's a very interesting thing. When I sleep, I felt like it's more actually while sleeping. But when I get up, that I felt like it's less. I don't know why it is that. So I took some painkiller for that. When I took
Okay.
painkiller, I felt a little better. When I took some, um, there's like naproxen, something, the drug name I took. I feel a little better when I took that one. Yeah.
Okay. Okay. I'm very much sorry to hear this, and I also
Mhm.
appreciate that as soon as you possible having pain and you come to me. It's very good.
Yes.
So is it constant and or on and off?
I guess it's quite constant, I would say. Yeah, but sometimes
Okay.
it's become quite intolerable actually. But it's always there, but sometimes it increases.
Sometimes. So when was your
Okay,
flu like
I would like to
this?
add one thing that actually when I walk or shift my position too much, okay,
Okay.
like even while I'm sleeping, if I just turn this side, that side, I feel like the pain is increasing.
Okay. So flat like you feel pain,
Yeah,
and
flat,
if you
or from this side, left
comfort,
side to
then
right
it's
side. Yeah,
increase.
so I'm just moving, I'm feeling more pain. Yeah.
Okay, okay. And so, can you show me the exact site of your pain? It's just a
Yeah, that's
central
like
pain.
centrally, yes.
Yeah, and from the note, I have also seen that it's radiating to shoulder.
Yes,
Okay,
yes.
okay. So, is this the first time?
Yeah, that's first time.
What were you doing when there is pain? Actually, what were you
Me,
doing at that time when
um,
first you develop chest pain? Is there any trauma injury or any
oh no, no, no,
something
like
like this?
I'm not sure. Like as I said, after I feel like after the infection, maybe this days I'm feeling this pain is
Okay.
little increasing. And yes, I mean when I walk, of course I don't feel good actually, especially climbing stairs and the things which makes
Okay.
things worse for me. Yes.
Okay, I understand that you are very much concerned about your condition, but
Mm,
don't worry, you are in now safe and we will do our
okay.
best to make you comfortable. Okay,
Sure.
so just couple of questions. Do you have any headache, blurry vision, or nasal congestion? Anything?
No, right now no.
Okay, any nausea, vomiting, cough?
Nausea maybe a little bit, not that much.
Okay, any breathing difficulty or noisy sound coming from your
No,
chest? Any tummy pain or any tummy distension than usual?
no.
Okay, any is there any what about your waterworks and bowel habit? Are those normal?
Fine, all good.
Okay, is there any shakiness, fever, rash? Any not like this,
Um,
right?
no, and I did fever. I felt like yes, and that's one point I want to add that I feel some fever actually, along with whenever
Or
this chest
just
pain
with
thing
the
is
flu-like
started.
illness?
Yeah, and fever is there. I mean, still, I guess actually, even yesterday I also was feeling a little feverish at the same time.
Okay, have you measured the temperature? And do you take any
Yeah,
medicine?
yeah, I took
Okay.
Panadol for that one actually, and it reaches around 101 highest so far. Not
And
that
that you
high, but 101 I
100.
have noticed highest. Yes.
Okay, do you take any medication for that? Panadol.
Panadol, yeah, it was fine with
Panadol.
Panadol actually. Like
Okay.
right now, I don't have much actually, but yesterday I had it.
Okay. Is there any lump and bump in your body or any recent weight loss? Nothing. Okay. Is there any recent travel history or you are you exposed to any this type of problem?
No, nothing like
Nothing. Okay. Is there any past medical illness that I should know, like hypertension, stroke, diabetes, bleeding disorder, anything?
no, nothing like that.
Any recent surgery
No.
or long term? Okay. Okay. And is there any family history of diabetes, chest disease, kidney disease like this?
Heart disease, I would say. I mean, I think my father is also having heart condition. He's still
Okay.
alive, but he has some heart conditions
Okay.
still.
Any early death of any? Okay.
No, not early death, but he has ischemic heart disease. All I know.
Okay. Are you on any medication?
Right now, no. I mean, just took the
Like
Panadol for that pain
any
actually.
heart? Okay. Okay. Any Viagra? Anything? No.
No.
No. Okay. Thank you, Eric. Karen? Thank you, Karen, answering my question. I would like to know about your physical findings from my examiner.
Sure.
I will back soon with the finding. Okay.
Thanks.
Okay. Examiner, what about my patient general appearance? Like, is he anxious, ill looking, sweaty?
Your patient is actually those things are negative, like the
Okay.
things you asked initially.
Okay? Is there any pallor, icterus, edema, dehydration, sinuses, clubbing present?
Negative.
Any lymphadenopathy or any thyroid swelling,
Negative.
rash present? What about my patient BMI?
Negative.
Is my patient
BMI
still
is 31.
sorry 31?
BMI is 31. Mhm.
31. Okay. And
Yeah.
what about my patient vital status? Is this the same before?
Same as before, actually.
Okay, I would like to do some quick examination of CVS. Like on inspection, I would like to know about is there any precordium side shape normal, scar mark visible, scar swelling
Negative.
is present, negative. I would like to know the on palpation, is there any local raising temperature, any swelling, apex beat, parasternal heave, thrill,
Nothing abnormalities detected on palpation. And move forward.
For it? Okay. Any then on auscultation, is there any pericardial rub
There is a noise present on auscultation.
noise present?
Yeah.
Okay. And okay, and a heart sound is audible in all four
Yeah,
ears.
S1, S2 present. Yes.
Okay. And
Then move
other
to the
systemic
next.
examinations are normal.
Other
Like
findings are normal, especially yes, respiratory finding is also normal.
okay. And is there any office test available like ECG, chest, ECG, urine dipstick test, blood sugar level?
It's present, like ECG others are negative and
In
ECG is
ECG?
present, and ECG is showing there is ST elevation is present there actually, and downsloping TP.
In all lit, I mean, lit 2
Yeah,
to 5, or
no,
just
it's like, yeah, it's like all over.
all over the world? Okay, thank you. Any other investigation available like chest
No,
X-ray?
no
No.
other investigation for now available
Okay.
actually. Thank you.
Okay. Thank you, examiner. So thank you, Karen, for waiting patiently. So based on the history, clinical finding, and ECG finding, I think most likely you have a condition known as acute pericarditis. Have you heard about it?
Okay. No, what's that?
Okay, let me draw a picture. This is heart, and
Okay.
this is the layer of your heart. Sometimes maybe there is fluid accumulation in between the membrane of the heart. Okay,
Okay.
so it usually follows some bug infection, like
Okay.
viral or
Yeah,
bacterial.
that's why maybe that infection I had. Is it
Yeah,
possible from
that's
that?
why you had upper respiratory
Infection.
tract infection 2 weeks
Mm-hmm.
back. Maybe it follows that. Maybe it is also follow other things like trauma or heart disease or kidney disease. But yeah, you have maybe possibly it is viral infection. The
Mm-hmm.
cause is mainly
Okay.
viral infection. So I was also thinking about other diseases, like maybe there is heart attack, but I don't get any sign symptom
Okay.
or
Okay.
physical finding from you. Like also I was thinking about infection of the lung, but I don't get any fever or cough in your history. I also thinking of fluid trapped in your chest, but you have no trauma history. Okay, are you with me so far, Karen?
Yeah. Yeah. Thanks. Yeah.
Okay,
Mm-hmm.
and also thinking of some trauma history or muscle spasm in your chest, but I don't get it. Also thinking about, okay, do you have any heartburn or anything like that?
No.
Okay, then it's not a stomach ulcer or any esophageal problem. Okay,
All right.
uh, and you are vitally stable, so there may be no rupture, anything. Okay,
All
so
right.
to exclude this, I will refer you, and I will do some. You will be seen by specialist. They will do some investigation like full body and also give treatment. They will tell about further management. Okay,
Sure.
and I will give this reading material. Please go through about this acute pericarditis,
Sure.
and after discharge, I will send you
Okay.
all
I'll
this detail.
meet you definitely. Yes.
He
Sure.
will review. Do you have any other question?
No, not for
Okay,
now
after
actually.
discharge, if
Thank you.
you have any cough on blood on cough or any intractable pain, please report to the emergency department as soon as possible. Okay.
All right. Definitely.
And
That's
don't worry, you are in we the specialist will do all the things to make you
Mhm.
comfortable, so you are in best hand. Okay.
Thank you so much, Doctor. All
Okay.
right, Dr. Sylvia, good job actually. What do you think, guys? How did she done actually? Apart from the time thing, how was the overall role play? I think it was well. I think apart from the just time, no, that's okay because time is something we
I
can
think
practice
that,
and reduce. No, but
uh,
your flow was good. Flow was
I think
actually,
that
you know,
you
and one
told
smart move. One smart move I like. You forget about asking ZID. You remembered it, and you smartly, ask me. Can I ask you something? So this is, guys. This thing will happen with many of you in the main exam. If you remember it suddenly, You just remember that, okay, you forget about to ask about the ZRD much. So, okay, can I ask you? So actually, it's like treat the patient like a normal patient, a normal, like, if you miss that in history, it's not like you cannot ask while explaining. So can I ask you something? Yes. And of course, like I said, like any heartburn thing, no, so it's not ZRDC. So, so it's interactive and communication and good presence of mind. So these are, important for the case. See, your diagnosis is also correct. Making correct diagnosis is also important because you see very less information in the question. When there is very less information in the question, that means you have to take, the history and the relevant things actually. It didn't lose point on that one. What so like, if you see the differential, so all of you did well. You did well here actually. Any shortness of breath, racing heart, that term bring it in your practice because a lot of cardiac problem are related to racing heart. Okay? So from now on, everyone please try adding that word, any shortness of breath, any racing heart. So racing heart is the word that will exclude all the palpitation cases because one of the DD in our cardiologists are the palpitation cases. So racing heart exclude that actually. So I think that one might be missing as a negative history. I would have more happy if you asked that one or any one of others in past asked that one, but you went in right direction. You asked about eventually you get to know this fever. You ask about the trauma history, ruling out aortic problems, death or sudden death in family, ruling out this. So DD ruling out was very well done actually. Any recent travel ruling out pulmonary embolism, any surgical procedure. So you are spot on into ruling out DD. You are spot on into the history thing. You do ask about, I guess, the allergy and also relevant things. Initially, there was few things about asking about the vitals. You are also comfortable on that one. That's optional actually for this case, but I would have appreciate like just if you can add an option. Uh, hey Karen, is there any way you are in a lot of stress? Because in those countries, it's very common. They are always in some lot of stress actually things. So the stress and stress induced problem, it can be possible. Then eventually, we talk about the position and the thing. It has been ruling out that um, I give some history that lying flat was causing or changing the position is causing more pain. Um, Immediately on the top of that one, doctor should ask about, um, do you have pain on deep inspiration? Did you ask that one, Dr. Sylvia? Pain on deep inspiration?
You told me that.
Yeah, okay, I told you that
You
one. Okay.
already told me.
Yeah,
I
I
think
told that
you
one.
take lots of time.
Oh, yeah. Good one. Yeah, that's true. Yeah, that's true. All right. So, and then there's the thing, is my patient is hemodynamically stable or not? You guys it in the beginning when you started. Then the Socrates wise is gone. Some of the places, you can save more time. Is actually the history taking. The history taking actually, I check the time. If I tell you total time was, I guess it's 12 minutes actually, total time. YouTube actually. So 11 and a half minutes or 12 minutes. So this is the part you all can work in time and can save time. So next part will be that managing time and smartly squeeze the things actually. Smartly squeeze the thing actually. So that will be more important in future actually. Yeah. Now I'll give you a tip to Dr. Sylvia. Like, for example, in the history part, sometimes because I know that the answer is come as no from the patient. So if you think we ask in that way, like say you're asking whether constant or intermittent, um, how about your pain? Is it constant? See, how about your pain? Is it constant? Because I was supposed to say it's constant. No, it's not constant. If it's constant, yes. But you said, what about your pain? Is it continuous or is it constant? Now, how many seconds it took for that question, and how many seconds it took when I asked, hey Karen, you have pain, you said, and is it constant? Yes. Like, you let me speak less, that will be better. This is one of the point actually for everyone. So you have pain, is it constant? Yes, actually. So you just, because you know the answer, because you already guessing this might be pericarditis. So in that case, you can flip the history thing a little bit. All right. So this few of the things you can add. And also sometimes we can do, I mean, opening statement, let the patient talk or role player talk more. In the other part, because if you get the vibe, this is a pericarditis, you can ask, is there any way, lying flat or deep inspiration causing more pain? Yes. Any travel history? No. I mean, let the patient talk in as a yes or no mostly. All right. After the initial opening statement. So those are some of the parts. Every second matters, right? So we can see a lot of places, I mean, not only for Dr. Sylvia, even for others, where we can technically save few seconds actually by asking a question and in a little different way. By asking a question in a little different way, we can save some seconds actually. Also, there's another tip I give to Dr. Um, I think Faiza in the beginning, that when we are asking, we can also ask few things collectively, like in the examination. Now others also follow that one. I saw that's nice actually. That how about your pallor, icterus, cyanosis, clubbing, and maybe colonychia. So I said negative, right? But many of the doctors used to practice that. How about your icterus? How about your that cyanosis, any clubbing? So see, so many questions are coming, but rather than that one collective question saves a lot of seconds actually. So we have to understand that one, and also sometime in future I'll also try to tell which some of the parts we can skip. Now, part in the skip, say if you feel like you're short of time, there is no such significant family history, right? No. I mean, I'll tell as a yes, no in that case. If it's supposed to come, no. I mean, pericarditis case, we're not expecting family history, right? So there is no such significant family history, right? Yeah. So like no such history. I mean, patient will tell in yes or no in that way, in that case. Rather than if you just give opening statement, is there any family history and the things? No, I mean, is there any death? So rather than just make it short, or you can just cross verify nothing significant in the family, like this because it's acting, nothing significant in family, right? Yeah, no, yeah, like nothing significant. Yeah, so in that case, you can save some time. um, your smoking alcohol habits, please, occasionally. Then you don't take any recreational drug, right? No. Any background? No. Okay, so some cases, just, I mean, I say yes, no, yes, no. We like to go, and facial expression and a lot of things. Uh, Everything together collectively will work at the same time actually, because with facial expression and some of the words might save some of our time in that way. All right. So in that way, if we proceed, as far as we concern, and we can see the history part takes our most of our time. And even if you see today, Dr. Faiza, Dr. Kaihan, Dr. Sylvia, three of the doctor role played. And in both cases, the issue was the history part, right? The history part was taking, because already when you finish history and getting into physical exam, most of you finished your 6 minute already, or 6.5 minute already. Okay, so I mean, all of three of you. Maybe Dr. Kaihan was a little quick in history taking part. Um, so this is the thing. So please practice on that history part, because physical examination part, it's moreover more specific to the point asking actually. In physical examination part, say when we started, to examine as my patient is the same as before, to continue, yes. To know about the general appearance, starting with icterus, pallor, cyanosis, and clubbing, negative, lymph node, negative, and edema, dehydration, thyroid, negative. I would like to ask about systemic examination, starting with cardiology. Is there any abnormalities in the inspection and palpation? No. Is there any finding in auscultation? Specifically, I want to know about, is there any added sound? Yes, there's noise present. It is a pericardial rub? Yes. Any murmur? No. Any respiratory finding or GIT finding? No. Any neurological finding which I should know? Now we can move forward. How many seconds is two, Dr. Sylvia? When I play that one, it's very quick, right? So this is one of the part. I mean, it takes, I think, even less than 30 seconds in my case actually. So that's one of the part, because sometimes we're just trying to be more nice and gentle, but thing can be also done technically by keeping the same expression and the thing. and can be done very nicely too. Yeah. So as I said, at the end, I will try to do some role play by myself, showing how to do it in tricky way. I remember most of my cases in exam, I try to finish by 7 minutes actually, not keeping it up to 8 minutes actually. So I will show you a few of them by doing with some of them. Those will be quick. I think I need another expert actually. Maybe Limon will be examiner. I'll be role player. I will try to show actually that one, like how quick it can be done actually. All right. So so that's the thing. Informations, history, Socrates. Yeah, you guys gone through that. Deep inspiration is pericardial pain increased by lying flat and deep inspiration. So this point is already out with might be history of viral infection in my case. Yeah. So I told that one. Doctor managed to exclude it very nicely. There was a viral infection thing. Yeah. Then the physical examination, as per I said, if it's an online based exam, physical examination will be in a thumbnail in a different side actually. So the PICL thing, vital, CVS, all these things were perfectly done. I also show you demonstration how it can be done so quickly. All right. So that's the part. Because yeah, I could ask more about GIT, hepatojugular reflux, but I know in my case it's not much required, right? So I said, is there any GIT finding that I should know? Is there any GIT finding that I should know? Nothing significant, move forward. But if you guys ask about mass, tenderness, organomegaly, all this thing, that will take separately again another 20 or 30 seconds, right? Just asking the GIT thing. So my approach was, is there anything abnormal in GIT I should know about? Nothing abnormal, move forward. So that's a smart way of communication, that that candidate is confident and he knows that the thing might not be significant. So you can move forward in that way. Right. So moving forward from that one, there's a ECG. So ECG, you might be given either the ECG to interpret, but more of the ECG interpretation might come in the main center-based exam. I mean, you will be supplied a paper like that and to interpret that ECG. All right, so that's different. So all you can see, I mean, in pericarditis, is more over ST elevation will be diffuse and downsloping TP. We're not getting into ECG right now. I'm just telling it actually. Okay, we have a channel, by the way. It also already reached 9,000 subscribers. So if you haven't, we'll post 1-2 videos also from MC Clinical in coming days about rules, regulation, new changes. So if anyone is new, you can also cross-check it and subscribe it later actually. So diagnosis by doctor was correct. That was acute pericarditis. Few points were there. One more point, if you have noticed, Dr. Sylvia, that I told that I took naproxen and it was relieving my pain. It's actually treatment of pericarditis, right? Technically, NSAID is the treatment of pericarditis. Anyways,
Yes, yes,
etiology,
Dr.
yeah, viral, neoplastic. You flip those nicely. That it can be, this situation can be because of renal and malignancy and other cause. So that I like about you. You did that one. Yeah, your management was not required treating my condition, so you didn't talk about treatment, so you were into your task. So that's good actually. Okay, so you see this picture, I hope you'll remember. What do you see, Dr. Sylvia? Let's interpret
Yes,
this picture.
flat line,
Yeah, flat,
line
increased
increase
pain.
and leaning
Yes,
forward
leaning forward and
is
reducing pain. Yes, and ST elevations. Yeah, ST elevations, diffuse, causes viral. It can be uremic, be due to renal. Treatment is NSAID. So sometimes little bit recapitulation, little memorizing things are also good actually. Yes. Okay. So differential source pericarditis, coronary problems, heart attack, any chest pain until proven otherwise. It's a MI until proven otherwise. Apart from that, aortic rupture, ZRD. ZRD was very smartly, I like that one. Pulmonary embolism, of course. All these chest pain causes, don't forget to exclude pulmonary embolism because that's a real emergency. And of course, the pneumothorax. And also you can see in the black box, especially that air entry bilaterally and equal. You can remove the video site. I mean, if it's coming to your screen, that's also okay. Yeah. So air entry equal in both lungs, excluding pneumothorax. Trauma history, muffled heart sound, JVP, exclude cardiac tamponade. Right? Yeah, all of them you can make one. If it's a chest pain more than 60 minutes and not improving in any drug and the thing that can be heart attack, right? Night symptom, bloating, ZRD, uh, pneumothorax tamponade points are given. Anyways, yeah. So Dr. Sylvia, come to video again. So here's a feedback time actually. Yes, I mean, your case was good. History was very good actually, to be honest. Um, History was done very well, to be honest, especially family and the others were taken nicely. Examination was good, spot on. DD and differential, but I still believe the Dr. Pfizer's DD explanation was, I mean, better. But you came up with the DDs, that was fine actually, and you explained shortly. Um, if I just go with your knowledge, that's probably a past case. That's the good news. But if I go with the time, yeah, that's the only point. If it has been 1 minute, little more than I could have give you pass, but it's almost 11 and a half minutes. So that's almost like a 3.5 minute or 4 minute. Your global scoring, I would also give you 4 actually. So if you go, as I said, if you go with the knowledge, probably take, so you can take it today as a past case, maybe from my side, knowledge wise. Just only thing was the little drawback was the time management. Main exam, they won't make it pass because of time, but the approach was good, thing were fine actually. You didn't miss any points actually, that's the thing. So someday I'd like to do the first role play because first role play sometimes is a little bit more difficult, but that's okay. You did very good job. Well done. Yeah. Congratulations.
Thank
Yeah.
you.
Okay. Good luck, actually. Yes. So that's the thing. And Dr. Kaihan and Dr. Pfizer, no need to be worried. You guys also did very well. Earlier, you did very well. So we have one last more. I mean, Dr. Natalie, I think, shows some expression to. Yes. Hello. Yes, Dr. Natalia. So good to see you. So our last case solved out a little longer today class, but that's okay. And as long as you guys are not much bored actually. So without any further delay, I will start the case and will give you feedback. Your 2 minutes start now.
Okay, thank you. Okay, I'm ready.
Right. So
Okay, hello, Mr. Williams. From previous notice, I know that you are going for traveling and you have last 3 months, you have shortness of breath. Could you please tell me a little bit more about your breathlessness? What does make it better and worse?
all right. Yeah, thank you for getting back to me. And so, doctor, I mean, thing happened. I mean, yes, I had a trip to Europe, and then there was probably a very long flight there, and then coming back after a few days, I developed this shortness of breath. So, which developed like a just like a 1.5 hours ago. Then my wife was nearby actually, so I just called her. She quickly picked me up, and we just quickly came to the hospital. And I think, as you can see, still been having little breathing issues, and at the same time, I'm feeling some chest pain, along with this breathing problem.
Do you have chest pain also?
Yeah, I have some chest pain also.
Okay. Can you please tell me what started earlier, breathlessness or chest pain?
I think both came almost to similar time actually. I started developing some chest pain at the same time I developed shortness of breath.
On the scale from 1 to 10, can you please describe your pain?
Yeah.
When 1 is less, 10 is hurts a lot.
Yeah, I feel like it could be like 8 on 10 right now.
Do you have allergy? I would like to suggest you some painkiller.
No allergy.
So I will ask
So,
nurse
yeah,
to clean the paracetamol.
All right.
Okay, and the examiner, because my patient has pain in chest, I would like to know is he stable or not.
He's stable enough to continue now. Thank you.
Okay, so his general appears, I understand he's alert. And I would like to know his vital signs, blood pressure.
All right. His pulse is currently 110. His blood pressure is 90/60. His temperature is 99 degree Fahrenheit at this moment, and his
Sorry, what is
saturation
temperature? Temperature?
98.4 degree Fahrenheit. And
Okay. I
his
don't understand
saturation.
Fahrenheit. I don't
Yeah.
understand the Fahrenheit.
Okay, it's 37 degrees centigrade.
37. Saturation?
His respiration rate is currently 28 breaths per minute, and his saturation is currently 95. Saturation
95.
is 95.
And the respiratory rate?
No, I think his respiratory rate is currently 28, and saturation
28.
is 90.
Okay.
Yeah, 28. Yes.
And blood pressure 90.
Yes, 90/60.
Okay. And he's stable.
Yeah.
Okay, thank you very much. So, dear Mr. Williams, could you please describe your pain? Where does it pain travel?
Yeah, so good question. I mean, I have pain I feel like in the center I have pain. And pain, I don't think so it's radiating. It's mostly in this particular near to the chest area somewhere actually. And I feel breathing problem right now along with my chest pain, and I'm sweating a lot actually right now because of that actually. Yeah.
And you mentioned you are sweating.
Yeah.
Okay, because I'm GP, and because patient has a low blood pressure and sweating, I would like to do ECG even he is stable. So I would like to know ECG result.
All right, his current ECG result is it's not very significant, but it's like Q1 S3 T3. There is some changes out there actually.
But acute or not?
Acute, but there is no ST elevation or this kind of changes. But S1 Q3 T3, there are some changes.
In S changes or in Q?
Q, it's okay. Q.
In Q, some changes.
Yeah.
But not ST. Okay.
No ST, yes.
So tell me please, is pain continuous or come and go?
I think it's continuous. I mean, it's like since it started, it's there. Actually, it's a continuous one.
Continuous, pain continuous, and changing and breathlessness.
Yeah.
Okay, besides pain and breathlessness, do you have any other symptoms like dizziness, palpitation, and
No, not really palpitation. No dizziness. No dizziness. No palpitation.
not palpitation, vomiting, headache,
No.
nausea, pain
No.
in abdomen, pain in the
No.
stomach?
No.
No. Could you please tell me something about the previous medical history?
I don't have any significant previous medical history of.
Okay.
Yeah.
Are you
like-
smoking? You using alcohol?
No, I don't use that.
Okay, and family history?
No.
Your relatives did not suffering with cardiac.
No, nothing like that.
Any surgery and allergies?
No surgery, simply.
Okay, so could you please wait a little bit, and I would like to ask examiner about your exam.
Sure.
Physical. I would like to know cyanosis, skin color, shape of his face, and a particular swelling of his face. And
okay.
Also,
the patient is, I mean, currently no cyanosis present.
no cyanosis.
No cyanosis present.
Okay. Okay. Jugular vena pressure.
Jugular venous pressure is at this moment, it's a bit raised in this side actually.
Okay.
Raised jellyfish is there.
So he has respiratory rate 28. So I would like to know trachea position.
Which one, sorry?
Trachea position.
Oh, bifurcation of the trachea. I mean, you
Yeah.
mean deviation of the trachea?
Yes.
Tracheal deviation. Okay, no deviation of the trachea.
Okay,
Yeah.
auscultation, can I hear, and percussion, can I hear some changing?
Can you repeat that one? I'm sorry.
Auscultation, percussion,
auscultation.
and auscultation
All right.
of yes.
All right. So there is nothing much, abnormalities detected on his inspection finding, and especially in the respiratory, such inspection and palpation finding, and auscultation finding. The breath sound was vesicular, and the
Okay.
breath sounds are bilaterally present.
Okay, S1, S1, S2, and normal.
Normal, yes.
Present. Is normal present?
Present.
Okay. And what are time of normal?
I didn't hear the last part. S1, S2 is present, yeah.
Okay, and I would like to know about his abdomen, any mass and tenderness, and liver size.
Yeah, actually, in the abdomen, there is some swelling is present when you press the abdomen, and there is some refluxes there.
Okay.
Mm-hmm.
And he has pitching edema, as I understand.
Yeah, pitching edema is there.
Okay, dear Mr. Williams, according to my examination and investigation, I can suggest that in the past you had some damage of your heart, and now condition you have it is called heart failure.
Okay. I'm a bit worried, doctor. So is it manageable?
It is treatable. However, you should, I will give you some advices, and if you will follow these advices,
Sure.
uh, we will fix your problem.
Will you give me some drugs for that, or?
I'm little bit worried about your blood pressure because you have blood pressure 1970. It is a little bit low.
Right.
So, and you have a respiratory rate 28. So also you have changes in your stomach, and I can think that it is can be also.
You have to hospitalize for this condition?
Yes, I will. I would suggest to improve your condition. I would like to send you to the hospital,
Okay.
and after hospital we will arrange the next meeting, and I will provide you information about your traveling. However,
Okay.
in this condition, traveling overseas is prohibited. Particularly, we have pandemic of COVID-19, so it is also contraindicated travel in this situation.
Okay. All right.
So, do you have any questions?
You said his condition is treatable. So
yes, this condition is treatable. However, in future you should have a special diet. You will take special medications which will improve your condition, and also I will send you to physiotherapist later.
Okay.
For special exercise to train your heart.
Okay.
And also you will go to cardiologist for check up.
All right. Okay, thank you so much. That helps. All right.
I hope it will help you.
All right. All right. So thank you, Dr. Natalia, for coming out and play that. It's a little complicated case actually, compared to the other three cases. Actually, this one was a little complicated, but you have good presence of mind, and your experience that shows actually, case wise. Before we getting into that one, let's see, check out some of the differentials for this case. Like, so guys, I mean, for this case, what can be some of the differentials? I mean, if you just want to add 5 or 6, I mean, it's open for everyone. So what are some of the differential for this case? Yes, we have, of course.
I would call kidney disease also. Because the chronic kidney disease can
good. Good. Yeah.
And COPD, yes, but asthma, not sure. Yeah.
So others, guys, I mean, what differentials you guys want to add here? I mean, all the cardiacs, maybe let's not take much time. All the cardiac things we can involve. Apart from that one, the respiratory conditions we can involve at the same time here. So you can see some cardiac, some respiratory, as like the before the causes, including that, so 5 A's and 5 P's. Is just a mnemonic to remember, 5 A's and the 5 P's actually. That's one of the thing you can consider here. Just give me a second. Yeah, so that was actually one of the last cases. I just want to show that in this can be a case of heart failure. So in heart failure case, especially the history has been taken. Mostly there's like breathing problem along with that one. So breathing difficulties were being one of the evident thing. And at the same time, yes, it's true, I was not giving the history in right way. So because some of the cases can be complicated, and also role players actually don't give, they will try to confuse you in some cases. But you will stick with your task. Eventually you get to know with the positive points like, edema, some of the other physical findings and relevant points, you came up to the diagnosis. This is a case of pulmonary edema, because key points were shortness of breath. That's one of the things, shortness of breath actually. Right. So that's the thing. I mean, here actually, I'll give you guys a little bit more feedback onto heart failure. I mean, probably next is a bit little late today.
I have a question. You told
Yeah, sure.
this case pulmonary edema.
In this case, because that long flight is a bit overlapping actually the situation.
Yeah,
Long
because
flight.
I asked you.
Yeah.
I asked you about any about respiratory system, and you told me that it's clear. In pulmonary edema, I should hear some crackles.
Yeah, so one of the part, that's why I'm saying that some cases you might not get exact the finding and the things, you have to ask few things exactly in that way. Like maybe because of the sound issue, maybe I missed that one. But the pulmonary edema and few of the things, you can ask specifically, is there any pulmonary edema? Is there any things like that? I might miss that one because of the sound thing. So sorry for that, if it's missed in any way. So key findings here, there can be crackle, there can be pulmonary edema, there can be some of those relevant things which will make your case positive for towards the heart failure. As I said, guys, I mean, it's a little late today. I mean, definitely, Dr. Natalia, next day I'll give you a bit little detailed feedback on this case actually. Okay, so I hope so that'll be fine for you. So it's a little to be continued for today. It's a bit late actually. I have to go for praying actually here. So good job actually. You did good job, except for the time it took, like almost 12 minutes. That's the only part. Yeah, so the time was taken 12 minutes, that I can tell you. Remaining some of the positive points I'll bring in the next class for the cardiac failure, and I hope so you'll enjoy. And I'm also feeling a little dizzy at the end, I guess. I hope so you'll ignore that. So we'll see you guys next class. Actually, our next class is on the Tuesday. We'll start from this case, don't worry. And I hope you guys enjoyed today with some presentation and the thing. So good luck to all of you. The syncope, if you guys get some time, you guys a little read about the syncope, okay, in the next class actually. Syncope and the things, if you guys read. So syncope related a lot of cases. So today was the chest pain related relevant cases actually. Some of the new recalls we also discussed and relevant thing we discussed. And hope to see you all in the next class. Thank you so much. This is Dr. Shahriar from the presentation.